Good afternoon, everyone. Um, I welcome us to the respiratory discussion. So today we are going to start the respiratory system, and we are going to start by talking about the obstructive lung disease first. So, um, what I just want to emphasize here is the fact that we should have it in mind that the major problem in obstructive lung disease is just impaired expiration. So that is the bulk of the problem in obstructive lung disease. They have problem with getting air out of their lungs, and that results in trapping of the air within the alveoli in the process, leading to hyperventilation. This is a diagram that is showing us the lung volumes and the lung capacity. And I know that in our step one, Dr. Babarinde will have talked about all these parameters. So we need to know them because we might get tested on it in our step one. Well, it's very commonly tested in our step two rather. It's very commonly tested in step one, but we never can tell. It might still show up in our step two. So let us just remind ourselves what is happening here. So we know that the amount of air that we take in and out in a single quiet breath is what we call the tidal volume. So somebody inspire and expire just calmly, nothing, no forced, expiration, no forced inspiration, just a normal quiet breath is called the tidal volume. So the amount of air that is exchanged, breathing in, breathing out, within a single quiet breath is known as the tidal volume. So, and that should be 500 mils. So if you look at this tracing, this is 2.7, and this is the upper part is 2.7, and the lower part is 2.2. So it means that if I'm just breathing quietly, I'm bringing in 500. So from here to here, 500, and I'm breathing out 500 from here to here. So 2.7 minus 2.2 is 0.5 liters, which is equivalent to 500 mils. The extra amount of air that I bring in after I have done the normal tidal inspiration is known as the inspiratory reserve volume. So if we look at this point now, so this person breathes in 500, breathes out another 500 tidal volume, breathes in another 500, but the person is now breathing in another extra volume after the normal 500 tidal volume. So that extra volume the person is breathing in with force is called the inspiratory reserve volume. So from here to here is the inspiratory reserve volume. So that means that inspiratory reserve volume is going to be 6.0, which is the total lung volume or total lung capacity, minus 2.7, which is going to be around 3.3 liters. So we just need to understand what it's all about. We don't really need to cram it. So that is the inspiratory reserve volume. That is tidal volume. Okay, I think some people are still outside. Okay, yeah. So the sum of the inspiratory reserve volume and the tidal volume gives us the inspiratory capacity. So if we look at the tracing, it's running from top to this point. So that means that the tidal volume plus the inspiratory reserve volume gives the inspiratory capacity. One thing about the capacity is that they are always a sum of two or more. It should be two or more. So sum of two or more volumes gives you a capacity. So here, inspiratory capacity is inspiratory reserve volume plus the tidal volume. Okay, so at the end of a normal tidal expiration, so let's say that this person now breathes in, breathes out, breathes in, breathes out, breathes in, breathes out. The amount of air that remains in the lung at the end of a normal tidal expiration, which is at this point, is known as the functional residual capacity. So it means that the amount of air that is going to remain in the lung at the end of a normal tidal expiration at this point is going to be from here to here, from here to here. So that is known as our functional residual capacity. But the thing is, that is after we have done a normal quiet expiration. But we can still try to bring out some air after the normal tidal expiration. Let's still try to bring out some air with force. What volume of air can you now breathe out when you try to force it at the end of a normal tidal expiration? The volume of air that you can breathe out is known as the expiratory reserve volume. So it means that after quiet expiration at this point, I can still breathe out from here to here, which is going to be from 2.2 to 1.2. That is 1 liter. So it means that the one that I can never bring out from my lung, it will never move out, is known as the residual volume. So it makes sense for us to define residual volume as in volume of air that remains in the lung at the end of a forced expiratory effort. So if somebody has tried his best to take air out, what is going to remain is going to be the the residual volume, which is about 1.2. So don't forget, the sum of the residual volume and the expiratory reserve volume brings about the functional residual capacity, while the sum of the tidal volume and the inspiratory reserve volume is the inspiratory capacity. Now, the residual volume um, plus the vital capacity is known as the total lung capacity. But before I get there, let me further break it down so that it doesn't get confusing. Now, the inspiratory reserve volume, the tidal volume, plus expiratory reserve volume are all known as the vital capacity. So that means we can say that vital capacity is the amount of air that you take out, that you take out forcefully after you have taken a maximal forceful inspiration. What do we mean? So let's look at this curve like this. So somebody is doing a normal tidal breath. You're just breathing in 500, breathing out 500, breathing in 500, breathing out 500, breathing in 500, breathing out 500, breathing 500. Then after this person has breathed in 500, the person now forcefully inhales the inspiratory reserve volume to take it to total lung capacity, to take it to 6 liters. Then after the person gets to this 6 liters, the person now forcefully exhales again, bringing it down to this portion. So it means that the total volume that this person has exchanged in that entire process is the sum of the tidal volume, the expiratory reserve volume, and the inspiratory reserve volume. So everything in total is called the vital capacity. So once you add the vital capacity plus residual volume, you get your total lung capacity. So that means that vital capacity is going to be the sum of IRV, TV, and ERV, which is 3.3 plus 500 plus 1, which is going to be around 3.8 or so, or 4.8 liters. So 4.8 liters plus 1.2 gives us the 6 liter. Please, do we understand this, or I need to? Anybody has any query anywhere? Let me try and see. Do we have any question to ask in that regard? Anybody? Okay, we are good. That's fine. Okay, so moving on to the test pattern. So of course, we have some tests that we do, which we call the pulmonary function test, to be able to see if the lung function is good or if there's some pathology. And on that basis, we're able to separate lung pathologies into two, the obstructive and the restrictive. There's no way we'll do our exam that will not see this. They will ask it is constant K. Score is always there. We'd see it. So, but plantain chips, if we just know what we need to know, we don't have to worry at all about it. So we give the person that tube, the spirometer. We tell the person to, try to take in air, then blow. That's it. So we try to measure the first expiratory volume in 1 second. The first expiratory volume in 1 second. That is the amount of air that you can breathe out in 1 second. And the first vital capacity, we have described the vital capacity. So we try to calculate the ratio of that. So normally, if we calculate the ratio in percentage, we expect to get a value of more than 70% or 0.7. That's a normal person. A normal person will always have a value of the FEV1 over the FVC to be more than 0.7 or to be more than 70%. But in an obstructive condition, it's lower than 70. While in a restrictive condition, it is normal or higher than 70. So we are going to get to that. Let's just hold on to that. In obstructive, it is lower than 70%. In restrictive, it is normal or higher than 70%. So what about the individual values? So we expect the other individual values to be more than 80%, not 70. Not 70 now. The other individual values. Please don't forget this. Many people forget they are using 70 throughout. No. The other individual values, for example, the FEV1, if you just measure it singly, it has to be more than 80%. 80% or more, but not more than 120. But the question, we're not going to get to testing more than 120. So just know that the normal should be like 80 to 120% of predicted. So FVC2 should be 80 to 120% of predicted, same as the functional residual capacity, which you said is a sum of the ERV and the residual volume. And also the total lung capacity should be 80 to 120% of the predicted. Now, the way I look at obstructive disease, we have said it, that obstructive disease is a problem of what phase of respiration? Anybody wants to tell us?
Expiratory.
The expiratory phase. So it's logical for us to assume that the FEV1 is going to be low in that kind of person. So if we are now looking at it in a form of a ratio, so we can say that in people with obstructive lung disease, we expect FEV1 to be lower than FVC. That's something. I want to use that to, explain what they mean by this. So now we already know that the major problem in obstructive lung disease is what? Expiration issues. So that means that their FEV1, which is the amount of air they can blow out, they can expire during during 1 second. At 1 second is the FEV1. So it's lower because they have problem with expiration. So that volume is lower in obstructive lung disease. So FVC, which is a vital capacity too, is lower in obstructive, but it can be normal sometimes. Don't forget, we have said that the major problem they have is what? Problem with expiration. Vital capacity also includes expiration, but we know that it involves some part of inspiration because you need to inspire first before you can expire. Don't forget, in vital capacity, you take a full, deep inspiratory effort and you now take a full, deep expiratory effort, to get your vital capacity. So functional vital capacity might be normal or might be reduced in obstructive. So that is why the ratio is always going to be less than 70 because the numerator is usually lower. It is always lower. So definitely that ratio is going to be less than 70. So don't be surprised in your exam if we now see arrow question saying that FEV1 is reduced and FVC is normal and we are now confused. No, we should not be confused. FVC might be normal in obstructive. Then don't forget, we said if they have problem with expiration, it means there's going to be air trapping. So that means that the air that remains in the lung at the end of expiration is going to be high because they cannot bring it out. So that is why the functional residual capacity is increased. The total lung capacity, which includes functional residual capacity too, is increased. So anybody wants to tell us what's going to happen to residual volume too in people with obstructive lung disease?
Increase.
It will be increased. In fact, it is because the residual volume is increased, that is why the functional residual capacity is increased. Because functional residual capacity contains the sum of residual volume and the expiratory reserve volume. So it is just, that's just the logic. Once you know that, there's no way they can twist that question, you will get it. FRC is going to be increased, TLC is going to be increased, residual volume is going to be increased because these are the volume of air that remains in the lung after expiration. So, and if you are having problem with expiration, you cannot take air out, those volume is going to increase. But what about restrictive? The only thing that increase in restrictive is the ratio. Anything else, it is low. Because people with restrictive lung disease, they don't have space in the lung. There's no space. It is shrunken. There's no way that lung can expand. If it's from a fibrotic condition, if it's from a neuromuscular issue too, it cannot expand. So there's no way it can create space for air to come in. So FEV1, FVC, FRC, TLC, everything is reduced. Everything is reduced in restrictive lung disease because it is a compliant lung that allows air to come in through inspiration that can be having air, to push out during expiration. But if you don't have any air coming in already, so it means that all the volumes are going to reduce. So that's why every volume in restrictive lung disease drops, but the ratio might be normal or increased. And the reason why the ratio increases is because they have they can have a drop in the FVC more than FEV. Don't forget, in obstructive, FEV drops more than FVC. That's why ratio is less than 0.7. But in restrictive, FVC drops more than FEV. Don't forget, before you can be measuring vital capacity, you need to take a deep maximal what? A deep maximal what? Anybody? A deep maximal what? Are we there?
Inspiration.
Exactly. You need to take a deep maximal inspiratory effort. So somebody that is having a restrictive lung disease cannot even do that because there's no space to take in the air. So that's why the FVC drops more than the FEV. So you can have an increased ratio. Yeah. So this is a loop. This is a loop. We don't actually need to waste any time. We can just code it. People with restrictive lung disease, the loop is going to shift to the right. So once you are seeing the loop shifting to the right, just look at the name restrictive har. It goes to the right. If it's obstructive, it goes to the left. And there's another thing that you are going to see in obstructive that would also increase your suspicion. We are going to see this cough, this indentation in the expiratory phase. So the one on top is the expiratory phase. The one beneath is the inspiratory phase. Don't forget the problem in obstructive lung disease is at expiration. So they are going to have that airway resistance, in expiration. But that is going to be absent in the restrictive lung disease. But the volume of air that can be taken in inspiration for restrictive lung disease is going to be reduced. That is why we are seeing this peak being lower than normal. This is a normal. This is a peak of inspiration for restrictive lung disease. So that is where the major problem is happening. So, but if this curve is kind of flat like this, it's not, following this kind of pattern. It's just flat like this. So that means that that problem is a fixed obstruction. Maybe somebody has, stenosis, tracheal stenosis or something. When the obstruction is fixed, so that means that there's going to be equal affectation of the expiratory phase and the inspiratory phase. So we should have that in mind. Once the cough is looking like a box like this, equal, just go and pick fixed obstruction. Okay. So what are the causes of obstructive lung disease? So we have the HEBICO, asthma, bronchiectasis, COPD, and tracheal or bronchial obstruction. Tracheal or bronchial obstruction. So we are starting with asthma, and we are all familiar with asthma. So this is just reversible. So the word reversible is very important. That differentiates asthma from COPD. COPD is irreversible. Asthma is reversible. So there is reversible airway obstruction due to four things. There is bronchial hyperreactivity. So that the bronchial airways are hypersensitive to allergens. It could be pollen, it could be dust, it could be anything. And when that allergen comes in, there's going to be inflammation because the white blood cells are going to react to heat to try to get it off. And due to that airway inflammation, there's stimulation of some goblet cells in the airway. They'll start releasing mucus, secreting mucin to try to clear off those inciting agents. And of course, the smooth muscles too are going to undergo hypertrophy in response to the inflammation. So these four things are common in people with asthma: bronchial hyperreactivity, airway inflammation, mucus plugging, and smooth muscle hypertrophy. So usually we diagnose asthma in childhood, but sometimes it can be diagnosed in early adulthood. So these are the major cytokines that play a role in asthma: histamine and leukotriene. Histamine and leukotriene. So we should have it in mind that not all situation of wheezing is asthma. So we should not be having some form of framing bias or some form of ascertainment bias that anytime we see wheezing, we're going to be picking asthma. It will be wrong. So you want to look at all the body of the history. You want to marry everything together to ensure that it fits asthma before you pick asthma, as your answer. So other things that can cause wheezing, that is not asthma include foreign body inhalation. So somebody have inhalation of foreign body, person can have wheezing. Somebody with cardiac failure can have cardiac wheezing. People with COPD, can also have wheezing. So somebody with asthma, how do we expect them to present? We are already familiar with this. We expect them to have the cough, the wheezing, which is usually episodic, depending on maybe the time of the day or when they are exposed to that inciting agent. They start having the wheezing, they start coughing, they start having difficulty breathing, which is dyspnea, and they complain of chest tightness. So usually these symptoms, these four things that we have said, usually can worsen at night or very early in the morning. So when we examine, we pick the wheezing, we notice that the time they spend in expiration is much more longer than in inspiration. Of course, we know that because there's resistance during expiration. So it takes a long time for them to get air out, rather than to get air in. So they might be using the accessory muscles, to breathe. They could have tachypnea, tachycardia, and of course, if you try to percuss the lungs, there's hyperresonance because of air trapping. So the important things to just pick here is just wheezing, the prolonged expiration, and the hyperresonance. So what are the signs we are going to see that would raise suspicion for a much more severe form of asthma? If the person is having reduced breath sounds. So at this point, it means that the accessory muscles, they're now getting tired. The person cannot even breathe very well. So the breath sound is going to drop. So people think that they are doing well, that they are getting better. No, they are not getting better because they are getting tired. They cannot even breathe again. So they are becoming cyanosis. O2 sat is dropping to as low as 70, 80%. There's problem. Or if they're having hypercapnia, because if there is respiratory muscle fatigue, the person will not be able to get air out. CO2 cannot come out. So CO2 is going to be retained in the blood, causing hypercapnia. So if somebody is having hypercapnia, there's a problem because somebody with asthma that is acute, we expect the person to be having tachypnea to get CO2 out. So, but if the person is having a very severe form of asthma that is getting tired, there's going to be hypercapnia because the person can no longer breathe very well to get CO2 out, CO2 gets retained, causing hypercapnia. So that's going to be like an example of a type 2 respiratory failure. So you want to have that at the back of your mind. Hypercapnia is a very, very bad sign. Then, of course, paroxysms and paradoxicals, which is like dropping the systolic blood pressure during inspiration. It means that air trapping and everything is increasing the pulmonary vascular resistance, and with expiration, you have a lot of blood clogging within the right side, with little moving to the left side. So the blood pressure will drop. So which is the pulsus paradoxicus? I know we know pulsus paradoxicus from our cardiology. So we should suspect asthma in a child that's having multiple episodes of croup or upper respiratory tract infection. There's an inflammatory niche already that is like setting the ground for all those infections to be coming in. So we are just having croup, respiratory tract infection every time. What's happening now? We want to evaluate for asthma. So people with eczema too and other allergic conditions like allergic rhinitis too should be evaluated for asthma because they can have it. So what are the triggers for asthma? We know the allergens: dust, mites, pollen, and all those things. It could even be upper respiratory tract infection. It could be cold hair. So people that, that's why in the morning it's very common. When it's cold, the cold air can easily incite asthmatic symptoms. Exercise. So people have exercise-induced asthma. It is only when they are exercising, when they are exerting themselves, that they develop the symptoms. So in somebody with exercise-induced asthma, because I might not be able to talk about it elsewhere, just know that most of the time they try to pre-medicate them. Like 10 to 30 minutes before they exercise, they give them, the inhaled corticosteroid and the LABA, which is a long-acting um, brachial, the, the long-acting beta agonist. So they give them the long-acting beta agonist with the inhaled corticosteroid about 10 to 30 minutes before the exercise. Sometimes they can also use the leukotriene receptor antagonist, which is like montelukast. They can give them like 2 hours before the exercise. So both of them, they work, in the treatment of exercise-induced asthma. So drugs can also precipitate asthma. We're going to talk about this shortly. So drugs like beta blocker, you don't want to give somebody with asthma beta blocker, because if you can't give beta blocker, there's going to be bronchoconstriction. So it can precipitate asthma. People with asthma, you don't give them aspirin, because if you give aspirin, you are going to shut down the prostaglandin synthesis pathway. Yeah. So that means that most of our arachidonic acid, they will be moving towards synthesis of leukotrienes. And aspirin cannot block. Aspirin is not a COX-2 inhibitor. They will block COX-1. So that means that all the COX-2 pathway is now going to be moving. So they are going to be forming leukotriene, and leukotriene will just be there unopposed, causing bronchoconstriction. So that is the pathophysiology of aspirin exacerbated respiratory disease. And this is just a condition in which somebody takes aspirin and they start developing some features, with time. And this includes asthma, number one. They have chronic rhinosinusitis. They're always sneezing, itching their nose, having discharge, chronic rhinosinusitis with nasal polyps. So if you have somebody with asthma, chronic rhinosinusitis with nasal polyps, and intolerance to aspirin, think about the Samstag triad, which is classic for aspirin exacerbated respiratory disease. So part of the evidence to the aspirin intolerance is that they are going to be complaining of rash anytime they take aspirin. They can complain of abdominal pain, vomiting. Once you see that, that's evidence of intolerance to aspirin. So the pathophysiology is just that aspirin is there inhibiting COX-1. So it means that if we give aspirin, COX-1 is blocked. There's nothing, to produce prostaglandin again. So prostaglandin are out. So it means that all our arachidonic acid that should be taken to prostaglandin, they are not taken to prostaglandin. So they are going to be taken to leukotriene. Don't forget, the leukotriene pathway requires lipoxygenase. So I'm so sorry about that. That's what I'm supposed to say, not COX-2. The the leukotriene synthesis pathway uses lipooxygenase. So with lipooxygenase unopposed, they are going to be producing a lot of leukotriene, and the leukotriene are going to be there causing bronchoconstriction. So that's what explains why they usually have like asthma in them. So that is not an allergic condition. So they could paint that scenario in the question, and some people, because they are rushing, they go and pick a type 1 hypersensitivity condition or allergic. No, it is a pseudo allergic reaction. It is not IgE mediated. Of the pathophysiology that we have discussed now, I have not mentioned IgE. So it is mediated by leukotriene. So don't pick IgE mediated. It is a pseudo allergic reaction. So that's the Samstag triad: asthma, chronic sinusitis with nasal polyps, and intolerance to aspirin. It is because of the chronic rhinosinusitis. There's always inflammation on the mucosa of the sinuses that leads to the formation of the nasal polyps. So if you see somebody having nasal polyps, know that the person is already having chronic rhinosinusitis. So let us keep that in mind. So we should suspect impending respiratory failure in a patient with severe asthma with a normal or a normalizing PaCO2 and pH. Of course, we have talked about this. So let us say that somebody is having asthma. Ideally, the pH of the person should be hyperventilating. So if the person is hyperventilating because of the asthma, the amount of CO2 in the blood is supposed to be low. So that means that the pH is supposed to be high, ideally. But when it's getting severe and the person is developing impending, or the person is almost developing respiratory failure, the respiratory muscles becomes weak. So the person will not be able to get out CO2 again. So CO2 gets retained in the blood, and the pH in that kind of person is going to start approaching normal or becomes low. So when pH that is like maybe at 8 initially when the person came, because the person was tachypnic, now suddenly drops to 6. Some people would think that he's stabilizing, he's doing well. No, it is because the person is already having respiratory failure. So the person cannot get out the acid, the CO2 again. So CO2 is accumulating, dropping the pH, and it can even further drop to like 4. So once you have like a normal pH or like a low pH, you know that you are suspecting um, a respiratory failure. So in that kind of situation, we want to measure the PCO2 to see the level it is, to know what to do next. Of course, the best next step would be to provide, the NIPPV, the non-invasive positive pressure ventilation, or you go and intubate, or you go and intubate, or you go and intubate. Very, very important. There are some contraindications to indication to NIPPV, which we are going to talk about shortly. So now we want to make diagnosis of asthma. How do we go about it? We are going to do our pulmonary function test. That is it. We are going to do our pulmonary function test, and we are going to see obstructive pattern. And one thing about it is that we expect that obstructive pattern to be reversible when we administer a short-acting beta-2 agonist like albuterol, like albuterol, like albuterol. So, but one thing I also want to say here is that the fact that we do spirometry test for somebody and the person does not have obstructive pattern does not rule out asthma. It doesn't. So that's when you have to proceed to the methacholine challenge test. Don't forget that stuff. Never forget it. So we bring in a patient, we want to diagnose asthma. We do the PFT and we see that FEV FVC ratio is less than 70. That's in keeping with asthma. We can now even measure the individual one, FEV1, FVC, FRC. Everything is going to be like low. No, sorry, the FEV and the FEV1 and the FVC, they are going to be low. They are going to be like, less than 80% of expected. It's going to be low. But because of hair trapping, we expect the residual volume to be high and the total lung capacity also to be high. Now, there's another parameter in asthma that they check, and that is the diffusing capacity for carbon monoxide, the DLCO. Don't forget this. The DLCO in asthma ideally will increase. Why? Because we use this DLCO to check for the diffusing capacity of the respiratory membrane. So how much can carbon monoxide pass through this respiratory membrane? In people with asthma, it is believed that the DLCO is going to be high because there's a lot of inflammatory process going on. So there is recruitment of vessels around this respiratory membrane. A lot of alveolar capillaries are kind of recruited, they are synthesized. So there's a lot of blood overwhelming that area, so allowing the carbon monoxide to easily diffuse across the membrane into the blood. So that is one of the postulations for why people with asthma have a high diffusing capacity for carbon monoxide because of the inflammatory process that's happening, in that airway. So DLCO is high in asthma, but it can be normal. If we see both of them in the option, please pick high. It is much more safer. So don't forget, this is a very good distinguishing feature of asthma from COPD, and we're going to talk about it shortly. So don't forget, we draw our pattern, is going to be less than 70. We measure FEV1, is going to be low. FVC might be normal or low. This is asthma. The one that is constantly low is FEV1. So what about residual volume? Total lung capacity, they will be high because of hair trapping. DLCO will be high but can be normal. So now, if we now do reversibility test, we now try to reverse this reduced FVC ratio. If we give Saba albuterol, is it going to go back to normal? Yes. So people with asthma, it usually goes back to normal. And how do we know that it has gone back to normal? You now check for your FEV1. Are you having an increase which is more than 12%? Or you are having like a absolute volume increase of more than 200 mils? So if you're having more than 20% increase in the FEV1 or volume increase of 200, you can say that that is a positive reversibility test. Now, this is where USMLE will now come. They will now give us a change of 10%. So people will now be saying that, maybe it has changed. It is reversible. No. If it's not up to 12%, don't pick. Don't pick. Don't pick it to be positive. That is not reversibility. It has not improved. It has to be more than 12% or more than 200 mil in absolute volume before you can say that it's reversible and you can now pick asthma. So they can be tricky. They will actually give you an increase, but the increase might not be up to 12. So it has to be 12 or more. It has to be 12 or more. In between exacerbation, PFT is normal. So that is why you don't do PFT and stop there and say that since the PFT is normal, this person is not having asthma. No. So if you are having a very high index of suspicion for asthma and you do your PFT and it is normal, so the best next step is to do methacholine challenge. Don't forget, step 2 is always about thinking, best next step. But everything is always about best next step. That is what you are going to be seeing in your exam. So if you only know one initial test, it's going to be a problem. We have to know the best next step. So if this is normal and we are suspecting asthma, what do we do next? Methacholine challenge. I will try to test for bronchial hyperresponsiveness. So what do we look out for? Because methacholine is an agent that causes bronchoconstriction. So we expect all the parameters to worsen. So if it's actually asthma, we expect the FEV1 to further decrease by 20%. We expect it to improve by 12%, but we expect it to decrease by what? 20% or more. Don't forget. So what do we expect when we do ABG in asthma? Respiratory alkalosis, I've explained this. In the early exacerbation, when the person is still all right, because they're hyperventilating, PCO2 drops. So there's going to be respiratory alkalosis. But late exacerbation, when it's getting worse and the person is having impending respiratory failure with respiratory muscle fatigue, we start noticing that the person cannot take out CO2 again. So CO2 is retained, leading to what? Respiratory acidosis. So that's a problem. Somebody with respiratory acidosis and the person is asthmatic, you want to go and intubate that person immediately ASAP because the person can die at any time. If you do X-ray, what are you going to see? Could be normal, and there could be feature of hyperinflation with flattening of the diaphragm because of what? Hair trapping. Because of hair trapping. So don't forget that. Hyperinflation because of hair trapping. So somebody comes in with asthma. What are the potential medications we can give them? We want to give them beta-2 agonists. That's like the first line drug. So there's a lot of them. We have the short-acting one, the SABA, short-acting beta-2 agonist. Short-acting beta-2 agonist that relax the bronchial smooth muscle. We call that albuterol. We have the long-acting one, which is salmeterol, but the best is formoterol. Formoterol is the best. Why? Because formoterol can act as both a reliever, medication and a controller medication. So when you say reliever, you want to relieve that acute event. Controller, you want to give it so that it can maintain bronchodilation like over a long period of time. So it means that if a drug wants to act as a reliever, it should have a fast onset of action. I give it, it dilate immediately. That is a reliever. And an example of that is albuterol. I give it, it relax that bronchial airway immediately. But for something to act as a controller, it should be able to do it for a long period of time. So that means it should have a long duration of action. So that is why salmeterol is good. You might not be able to do it fast. You might not be able to relax that bronchial airway immediately, but it will be able to do it for a long time. So that's salmeterol. But the one that can do both is formoterol. It will do it immediately and it will do it for a long period of time. So it can act as a controller or a maintenance as well as a reliever therapy. So if you want to give anybody any drug, any beta 2 agonist, give formoterol, you know. And according to the GINA guideline now, we always have to combine with ICS, and I'm going to show us that algorithm shortly. So those are the medications you want to give. You know, the beta 2 agonist, we have talked about them one by one. The next one is steroids because you want to control that inflammation too. So it's part of the maintenance therapy. So you can give Beclo and or prednisolone. So we remember the way they work on pharmacology. We should not forget all this pharmacology. We will need it in our step 3. So, we should always familiarize ourselves with. So they inhibit synthesis of cytokines. That's what the steroid do. So for asthma, they are usually given inhaled, and we're going to talk about it. Then muscarinic antagonist, not beta 2 agonist now, but muscarinic antagonist, they are going to relax too. We have the short acting, which is ipratropium, and we have the long acting, which is tiotropium. The mirtazapine, like theophylline, they can cause bronchodilation, but those ones are like third, fourth, fifth line. They are like up, because they have narrow therapeutic index. Narrow therapeutic index. They have a very high tendency to cause cardiotoxicity with arrhythmias and neurotoxicity with seizures. So just don't give it anyhow. Cromolyn. So these are like mast cell stabilizers. The mast cell stabilizers preventing degranulation of mast cells, cromolyn. Nedochromyl and cromolyn. Nedochromyl and cromolyn. Then we have the anti-leukotriene. So which like the receptor blockers, the anti-leukotriene receptor blockers. I mentioned one, montelukast, zefalukast. They're very good in treating exercise-induced asthma. So those are the receptor blockers. And we also have the one that inhibits the enzyme itself, the lipoxygenase enzyme, and that is Xilitol. Xilitol. We have the anti-IgE monoclonal antibody, example omalizumab. It's very useful guy. Talk about it a lot. Then the anti-interleukin 5 and interleukin 5 receptor antagonist, because these guys are very important in recruiting the eosinophils. And we know that the eosinophils play a very large role in mediating the pathophysiology asthma. So don't worry about it. But if you want to learn it, you can. Mepolizumab and benralizumab. Then we have the anti-interleukin 4 receptor blocker like dupilumab. So moving on to the guideline for the treatment. So we are working with the GINA guideline, and we apply this GINA guideline to an individual that's more than 12 years. So we need to know this guideline, very important for our exam, very, very important. And it's broken down into 5 steps, or like, let me say 4 basic steps. So the fifth one is just like more like an addition. So what you just want to look at in the question is, what is a symptom pattern of this person? How many times is this person having symptoms in a month? If the person is having symptoms less than 2 times in a month, step 1. If it's more than 2 times in a month, step 2. But the reason why I don't really bother myself about step 1, step 2 is that regardless, if step 1 or step 2, we are still giving the same thing. What are we giving? As needed. As needed. Inhaled corticosteroid with formoterol. That is what we are giving them. It is as needed, as they need. Okay, you want it now, take it. You want it now, take it. Oh yeah, take it. It's not that we give them every day. That no, have you taken it? Have you taken it? Go and take it. Have you taken it? Go and take it. You have to take it every day. No, it is as needed. Are you feeling like as if you want to choke right now? You want, oh yeah, go and take it. That is as needed. So it is not a constant K stuff. That is for step 1 and step 2. In step 3, this is what you likely get, because they know that many people forget this. They forget it. So step 3, what are you looking out for? Is this person waking at least once? Once the person is waking at least once in the night per week, please mind what I said. I did not say per month. Per week, you are waking up at least once in the night. Step 3. Or you are having the symptoms on most of the days, like every day you are having it. Not in the night, but every day you are having it. 6 times in a week you are having it. That's like every day. Step 3. What are you doing in your step 3? You are giving daily low dose maintenance with LABA. So I'm giving low dose ICS with LABA. Low dose daily, that's what they call maintenance. Low dose daily ICS with LABA. Once is step 3. So what's the difference between step 3 and step 4? Step 3 is the same thing as step 4. The only difference is that when you now do PFT of the person with step 3 is now very bad. So the person has a low lung function. So you want to step up to step 4. And what are you doing in step 4? You are just changing the dose. You are just giving either medium or high dose ICS with LABA. The LABA we are going to choose here, anybody knows the LABA we are using? What LABA are we going to use? Anybody? From what we have discussed so far.
Salmeterol.
Formoterol.
Formoterol, not salmeterol.
Formoterol. Okay.
Formoterol. Formo is the one that have both reliever and the maintenance. So Formo is the best bet you are looking for in your exam. Formoterol or the ICS. Very, very important stuff. So if you have now treated the person for step 4, you have given medium or high dose ICS plus LABA, which is Formoterol, and it's not working, you now go to step 5, which is to add LAMA to it. Ideally, you don't use LAMA alone. Never pick LAMA alone to be the answer. It will be wrong. Never pick it. It will be wrong. You have to use LAMA with a LABA. It has to be combined. We don't use it alone. So, or you assess for the phenotype. Is this person having exercise induced? Is it having maybe obesity, or something? You assess for the phenotype, and you manage accordingly. You can introduce maybe the omalizumab, which is a monoclonal antibody, or the anti-interleukin 5R. But trust me, it doesn't usually get to this. They will have stopped from somewhere between step 1 to step 4. So don't forget about that. Look at the symptom. How many times are you having it in the night per week? Once in the night in a week. That's step 3 automatically. Most days in a week, step 3. And what are you doing? Daily ICS plus LABA. Very, very important. So before you step up, you want to try to ask the patient, can you show me how you are using it? Because some people are just not using it the right way. How many times are you using it? Are you complying with the instructed time? Are you stepping away from the allergen? Are you preventing exposure to allergen? Or you are just sleeping with cats? You are sleeping with, all the house is full of mold. The house is so dirty, full of cobweb and all those things. So you want to evaluate that the person is avoiding the trigger before you now step up or step down the medication. So that's a general guideline for asthma. Okay, so let us go to the exacerbation. So somebody comes into the hospital with like feature of asthmatic exacerbation. How do we manage? So we want to, of course, do like for where the system is working, they have ABG quickly, they've done it. O2 SAT, they have all the parameters. So if the oxygen saturation is low, you want to give them oxygen, take it to about 93 to 95%. Don't forget, you might administer like shock tacting, reliever medication, to quickly relieve that obstruction. So you can give like SABA, first line, like albuterol. And you also want to administer inhaled corticosteroid like, prednisolone that we saw initially, or beclomethasone, anyone that is available. So sometimes you might combine, SABA with SAMA, which is what? Albuterol with ipratropium. Especially when it's very, very severe. And sometimes you can introduce magnesium too if it's very severe. Never use it. We have said you don't use your muscarinic agonists, you don't use them alone. But when USMA will now wait for us again is situation where we want to do high PPV or intubation. So somebody is coming in with difficulty in breathing, chest tightness, cough, and we do the PCO2, it is more than 50. Or this person is having like autosensorium, confusion, cyanosis, difficulty, like the chest is silent, decreased breath sound. We know that there's a problem. So in that kind of person, you want to provide respiratory support immediately. You want to intubate. But sometimes you might need to do NHI PPV first. NHI PPV first, which is used of like non-invasive positive pressure ventilation. So we are not intubating. We are not going inside their airway. We are just applying the max to deliver positive pressure so that we can keep the airways open, especially during expiration, which is a problem that they experience. So you can do that first if you are seeing all these respiratory muscle fatigue, blah blah blah. But there are some conditions that you will not want to consider NIPPV first. Example, if the person is having altered sensorium. So let me say somebody comes in now and the PCO2 is more than 50. That is telling us that this person is having respiratory muscle failure. There's respiratory failure already. With PCO2 greater than 50, respiratory failure. So you want to consider intubation or NIPPV. But now, the person having altered sensorium, you will not do NIPPV because their airways is not protected with the marks. They can aspirate. So you want to intubate. You want to intubate them. Or maybe there are burns injury on the face that you cannot apply the face mark to that face. You want to do, intubation in that setting. So if there's any problem with the face or there's any problem with maintaining the airway, maybe from altered sensorium, you want to do intubation. But if there's no contraindication to NIPPV, you can start that first. It's less invasive, it's less stressful for the physician. They can quickly do that, compared to intubating. So let's have that at the back of our mind. So we have talked about the treatment. So sometimes you can just give formoterol plus ICS, very good. But if we don't see that in the question, just pick our reliever medication, which is albuterol, and administer inhaled steroid with it, and you move. That's it. If there's a need for respiratory support, maybe NIPPV, go and do it. Or there's a need for intubation, go and do it. Please look at the question very well to be sure before you pick anything. So what are the side effects of the steroid, the inhaled steroid? So, it can lead to thrush. I've talked about this. It can lead to dysphonia. It can have laryngeal myopathy, so that is that. So adult and adolescent can benefit from the low dose ICS because it helps to improve lung function, reduction in symptoms, exacerbation mortality, and of course, disease. Okay, that's just by the way. So let us look at the question here, to see. I think I have only one question or so for this one. Let's just see if we are following. So this is a 15-year-old boy who is brought to the physician because of recurrent episode of shortness of breath, chest tightness, non-productive cough that first started about 4 months ago. He says that these episodes usually occur during or shortly after soccer practice and resolve spontaneously when he stops exercising. He has no shortness of breath at other times, including at night. The sister has allergic rhinitis, and his pulse is 68. Respiration at 14, blood pressure is 120, pulse oximetry shows oxygen saturation at 98. Physical examination shows normality. Spirometry shows FEV1 FVC ratio of 0.88 and FEV1 at 91% of predicted. Bronchodilator responsiveness testing is negative. Which of following is the most appropriate next step in diagnosis? A. Skin prick. B. Single breath diffusing capacity. C. Chest X-ray. D. Eosinophils and total Hg concentration. E. No further workup. F. Methacholine challenge test. Anybody?
Methacholine challenge test.
Methacholine challenge test. Thank you. So this guy is having something that looks like asthma. If you look at the presentation, but they have done the spirometry. It is negative. It does not mean that this person doesn't have asthma. So proceed to do the methacholine challenge test. And what do you expect, doc? If you do the methacholine challenge test, so what do you expect for the FEV? If it's asthma, what do we expect? My people, please.
It will decrease.
Focus.
By 20%.
Exactly. It will worsen by 20%. Okay. So that's all about asthma. So please keep in mind that NIPPV and intubation we have talked about. Signs of respiratory failure: reduced chest breath sounds, cyanosis, PCO2 greater than 50, altered sensorial. Once they tell you that the patient is confused, don't mind them, just be looking for intubation or NIPPV. Of course, you cannot do NIPPV like that because it's confused. So, altered sensorial, person might aspirate. So, intubation will be the best in that situation. That is the way to go about all these things. So, moving on to bronchiectasis. What is bronchiectasis? This is just a condition in which you have recurrent cycle of infection and inflammation of the bronchioles and the bronchial walls, with fibrosis, remodeling, and dilatation. The word here is permanent dilatation of the bronchial. That is a major problem in bronchiectasis. There is permanent dilatation of the bronchial due to the fibrosis, the remodeling, that they experience. And what is the cause of this fibrosis and the remodeling? It is because of the persistent inflammation and infection that occurs in the bronchial airways. Now, what are the three pathophysiologic bases for bronchiectasis? Number one, there's bronchial obstruction and mucostasis. Bronchial obstruction: is this person having a tumor? Somebody can have a tumor in the lung, particularly the bronchial carcinoma tumor that obstructs the airway, and there's going to be mucus accumulating distal to that obstruction, leading to infection and inflammation like that will be perpetrating like that in cycles until there is fibrosis, remodeling, and permanent dilatation of the bronchial wall. Mucostasis: if this person has cystic fibrosis, there's a lot of mucus being produced in people with cystic fibrosis, and the mucus even sticky. It's a problem. It will not move. There's mucostasis. They can have bronchiectasis. So once you see bronchiectasis, think about cystic fibrosis. Very, very good, causative factor. Or is it that the person is having low immunoglobulin or autoimmune problems? Why can't this person fight this recurrent cycle of infection? They're having like a low IgG or IgM or IgA, especially all those people with the congenital immunodeficiency, the Bruchtin, the common variable, SCID, and the likes. They can have it because they cannot fight infection. Infection will just be coming, destroying, it will resolve, it will come again, destroy, till they have permanent dilatation of the bronchial airways. Autoimmune disease too, SLE, rheumatoid arthritis, yes, they can be implicated. Or even people with chronic past infection like tuberculosis, they could also cause like serial, inflammation that can lead to permanent dilatation of the bronchial airway. Or what you just need is just something that can be causing recurrent inflammation that will destroy the bronchial airway. That is just what you need, And, what is going to be the history that would raise our suspicion for bronchiectasis? Just look for recurrent, productive cough. It has to be productive. They will be having some productive cough that is recurrent. They will tell us that the person is having productive cough, but what's the person coughing? Something that is like purulent or black or green, it will have some abnormal color. And they can also help us. They can go to town and help us that there's actually halitosis or hemoptysis. Once you see somebody coughing blood or somebody having a foul-smelling breath with a recurrent cough, just go and pick bronchiectasis. Just go and close your eye and pick bronchiectasis. You'll be correct in 90% of the situation. Hemoptysis, halitosis, productive cough, it's bronchiectasis until otherwise proven. So what are the underlying risk factors? Cystic fibrosis, we have talked about it. Recurrent pulmonary infection, from pseudomonas and the likes. People having allergic bronchopulmonary aspergillosis. We are going to talk about this shortly. So when I was talking about the autoimmune problems, this one is part. So allergic bronchopulmonary aspergillosis is part. So people with localized airway obstruction from tumor, autoimmune disease, IBD, and the like. So the patient is going to having rales, wheezing, wheezing, especially if it's due to obstruction. And of course, bronchitis is true, one of those obstructive lung diseases, so there's definitely going to be obstruction because of the mucus pulling in the airway. So, and of course, occasional hemoptysis. So, the hemoptysis actually comes from the recurrent inflammation, with the blood vessels being fragile, and they can easily rupture. If inflammation is too much, all the vessels there will be fragile and they can rupture, and the person will start coughing blood. So, purulent mucus, don't forget that. Foul smelling, hemoptysis, recurring cough, bronchitis. You can do chest X-ray, you are going to see this, not very important. The most accurate test to do is high resolution CT scan. Don't ever forget this. High resolution CT scan is the most accurate test to do. And what are we looking at? We are looking at the dilated airway. We are looking at what we call the signet ring appearance. Let me see. I don't know if I have this. So we are looking for the signet ring appearance. Now, it's believed that people with bronchitis, they usually have the bronchial airway larger than the vessels. So if we look at this picture now, you see, this part here is going to be the pulmonary artery. This hollow space here is the bronchial airway. Ideally, the bronchial airway should be almost the same size as the artery. They should be the same size. But people with bronchitis, because of the dilatation, it will be shown that the bronchial wall is going to be larger in diameter compared to the vessels. So that's more like what you call the signet ring appearance. So the arteries, the bronchial hair opening is going to be more than the surrounding pulmonary artery, like that. So you can see all this dilatation. You can see this one very dilated. You can see the dilatation here too. You can see this dilatation here, this dilatation, this dilatation. So that's like signet ring appearance, classic for bronchitis. This is also bronchitis. You can see the dilatation everywhere here. You can see this massive dilatation. That is bronchitis on CT scan. So we're going to see the signet ring appearance, and at the end we are going to be seeing some balloon cysts at the end of these bronchioles, especially at the lower lobe. So don't forget that the airways will appear large by the time we do CT, high resolution CT. And because of the fact that it is an obstructive lung condition, there's mucus being produced, a lot of inflammation. They will occlude the lumen of these bronchial airways. So the spirometry test is going to be showing something consistent with obstructive pattern. Very important. So if you want to manage, you could do some additional tests to look for underlying pathology. So we have talked about it. You can do of course, in the X-ray, if it's a tumor, you will have seen it. If you are thinking it's an infection, you can do sputum culture to see is there an infection. If it's due to allergic bronchopulmonary aspergillosis, you could check the IgE level, eosinophil count. If it's due to cystic fibrosis, do cystic fibrosis tests, those sweat tests and the likes. Tuberculosis, evaluate for tuberculosis. So autoimmune and ANA, rheumatoid factor, and all those things, check to rule them out. So that's that about the test that we do. Then how do we manage bronchitis? Because of the fact that there is a periodic infection and inflammation, so you want to give antibiotic cover for the exacerbation. So give antibiotics. And what are the preferred empiric antibiotics? We are going to give antibiotics that can cover respiratory tract infections, like the levofloxacin, the empiric,
Chlorophyll. Chlorophyll.
the
Chlorophyll.
yes. So sorry, the fluoroquinolone like levofloxacin and moxifloxacin. The moxifloxacin and the levofloxacin. So then you also do the culture to see, the specific organism that was, identified. Then you tailor your antibiotic to that, culture result. Then if it was triggered by allergic bronchopulmonary aspergillosis, you must administer steroids to reduce the inflammation, and of course give antifungal, because the cause of allergic bronchopulmonary aspergillosis is Aspergillus organism. So give Vori or itraconazole. The first line is actually itraconazole. Itraconazole is preferred. But if you don't see itraconazole in the question, just go and pick voriconazole with your steroid to treat ABPA. So you want to encourage some lifestyle changes. So you want to give them like incentive spirometry. So that blow that they usually blow in the hospital to keep the airways open. So incentive spirometry to clear the mucus. You can give expectorant to help liquefy the mucus so that they can take it out. Postural drainage, so they put their head down, and of course you can give mucolytics like Donnis alpha. Sometimes it's very bad. You can do surgery, lobectomy for a localized one, or you can just go and transplant that lung. Transplant the lung, if it's very, very bad. So don't forget, the first line is just to give antibiotic cover, empirically, proquinolones. Anything your culture, says, tailor the treatment to it. Then if it's due to ABPA, give steroid with voriconazole or itraconazole. And of course, some lifestyle changes to incentive spirometry, mucolytics, to promote the mucus clearance. And most of the time, it will not get to surgery. It won't, unless the person is having like severe hemoptysis that cannot be controlled. Normal, initial stabilizing methods like maybe embolization and the likes. Then you can now go and do surgery. So let me see if I have a question on the bronchiectasis. I have a lot of questions. Wow. Okay. So let us look at this. Just a minute, I'm coming. So, a 49-year-old woman comes to the office due to coughing of blood. This patient states that she's always sick with chest cold. She reports chronic cough with daily production of copious, thick, yellowish mucus that has gradually worsened over the past 10 years. Recently, the sputum has been sticked with bright red blood, and on few occasions, she has expectorated more blood and mucus. Medical history includes several episodes of bacterial sinusitis and lower respiratory tract infection. The patient currently takes no meds other than guaifenesin as needed and an antacid for occasional heartburn. She has never smoked cigarettes and rarely drinks alcohol. Temperature is 36.9, blood pressure is 112/60, pulse is 81, the nasal passages are clear and the signs are non-tender. Cardiovascular examination is normal. Lung auscultation is notable for coarse, wet biphasic crackles, diffusely that improve after coughing. Skin examination is normal. Which of following is the most likely cause of this patient hemoptysis? Anybody? Hello?
Bronchiectasis.
Bronchiectasis.
Yes.
Yeah, let's look at this. This one is a little bit tough, so we have to look at it, open our mind. A 24-year-old man comes to the office due to worsening productive cough with tenacious sputum, fever, shortness of breath for a week. Today, he noticed blood streaks in the sputum. The patient had several episodes in the past, and the symptoms usually improved somewhat with antibiotics but never went away completely. He also had decreased exercise tolerance, fatigue, and weight loss. The patient does not use tobacco, alcohol, or illicit drugs. There's no family history of similar problems. Temperature is high. Blood pressure is 130, pulse is 102, respiration is 20. Examination shows crackles in both upper lung fields and heart sounds are normal without murmurs. The patient's abdomen is soft, non-tender without organomegaly. Digital clubbing is present. Leukocyte count is 15,000. Chest X-ray revealed a right upper lobe infiltrate and the sputum culture grew Pseudomonas aeruginosa. Which of following is the most likely underlying cause of this patient's current symptoms?
Cystic fibrosis.
Defective.
Why?
Right.
Why are we picking cystic fibrosis? Why?
Okay, like the what took me there was the presence of Pseudomonas aeruginosa as one of the causes, usually after the age of 20 or in a bit older people, it is the most common cause of infection
Mhm.
in those people with cystic fibrosis. The younger ones, you will have Staph aureus. So,
That's very
defective.
good. Thank you, Doc. Thank you, Doc. All right.
I don't know.
So, moving on to COPD. So, COPD is also like very similar to asthma, but it's just that COPD is irreversible. So, it is a disease of reduced lung function with associated airflow obstruction, just like asthma. There's airflow obstruction here. And COPD is like an umbrella term for two major diagnoses. The first is chronic bronchitis, and the second is emphysema. Chronic bronchitis and emphysema. So, in chronic bronchitis, there is productive cough for more than 3 months per year for 2 consecutive years. It means that this is a clinical diagnosis. So, if the question tells us that somebody has been coughing for 3 months over 2 years, you just told us somebody has been coughing for 3 months over 2 years, just go and pick chronic bronchitis. It is as simple as that. Many people will still be confused, but don't forget, chronic bronchitis is a clinical diagnosis. And one thing about it is that the cough is usually productive. You know that there's something going on with a lot of inflammation, mucus production. So it's always productive. Because if a cough is not productive, the diagnosis is going to be another thing, and we are going to get there. So it's going to be within all those restrictive lung diseases. But once it's productive for more than 3 months, over 2 years, chronic bronchitis. Emphysema is not clinical. Emphysema is a pathologic diagnosis. You have to do like lung check to see the damage. So it's the one that all this pathology, people with morbid anatomy, those are the one that can make diagnosis of emphysema. So what happens in emphysema is that there is destruction and dilatation of the structures which are distal to the terminal bronchioles. So there is destruction and dilatation of the respiratory bronchioles and the alveoli. That's what they are telling us in emphysema. So, and there are two major risk factors for COPD: smoking and alpha-1 antitrypsin deficiency. So, people that smoke, they can easily develop chronic bronchitis. Usually, they will have chronic bronchitis. People that smoke can have emphysema, and people that have alpha-1 antitrypsin deficiency can also have emphysema. So, the major risk factor for chronic bronchitis is smoking. The risk factors for emphysema include smoking and alpha-1 antitrypsin deficiency. But the pattern of the pathology differs for smoking and alpha-1. So if it's smoking, it's going to be centrilobular. So most of the changes, the destructive changes, they are going to be confined to the upper part of the lungs. Why in alpha-1 antitrypsin, it is panlobular. So they usually have it at the base, the lower part of the lungs. So when they are telling us that somebody is having some changes, destructive changes of the bronchioles in the lower part of the lung, know that what they are telling us about is panlobular. The way I remember it is a pan. Pan, we put the pan on the fire. So what burns, the fire burnt the base of the pan. So that means that if it's panlobular, it's going to be the base of the lungs. The centrilobular usually affect the upper part of the lungs. So in emphysema, what happens is that there is, if this is the lungs, and we have the alveoli here, like that. They have some elastic cartilage that surround them, like this, elastic cartilage that surround them like this, so that they can expand when air comes in. So if this is the alveoli, it has some surrounding elastic cartilage like this that can make it expand. But what happens is that people with alpha-1 antitrypsin deficiency, they don't have this alpha-1 antitrypsin, so it means that the neutrophils can easily come into this lung, and they will use their enzyme that they call neutrophil elastase to digest these elastic fibers. So with that, these lungs will not be able to expand, stretch again, so they will collapse. That is it. people with smoking, they have a lot of inflammation in the lungs. Recruit neutrophils. Neutrophils will release their neutrophilic elastase that is going to damage the elastic fibers, and the alveoli cannot expand, and they will collapse. What do we think is going to happen to the compliance in people with COPD from this analogy? What is going to happen to the compliance? Is it going to increase or reduce? Anybody?
Decrease.
It's going to decrease because they cannot expand, so they just keep collapsing like that. So it's going to be reduced. Okay. So okay. So that's that about the causes of emphysema. Just remember smoking, remember alpha-1 antitrypsin deficiency. So
Yeah. Excuse me, sir. One second now. Could you please check the neutrophil elastase activity once again? I think I missed that point.
So in the alveoli,
Exactly.
they have elastic fibers that surround them, right? So they can help in elastic recoil, they can help in expansion. The neutrophils, they come in, they have neutrophilic elastase, but God put in alpha-1 antitrypsin in place so that by the neutrophils, by the time they come to the lungs and release their elastase to digest this elastin on the alveoli, the alpha-1 antitrypsin are there to stop that from happening. So anybody with alpha-1 antitrypsin deficiency would have unopposed destruction of this elastin by the neutrophilic elastase. Do we get that now?
Very well. Thank you.
So that is the pathophysiology of COPD, emphysema specifically. So, but in chronic bronchitis, the pathophysiology is just smoking, causing a lot of inflammation, goblet cell hyperplasia, a lot of mucus being secreted like that in the airway. So chronic bronchitis does not affect the alveoli, and that has meaning, and we're going to get there. So let's look at this key fact because it's important. People with COPD have chronic hypercapnia. Now, the way I want us to look at COPD is that it is a chronic event. So it means that these people, they're already tired. Though. Anybody with COPD, because it's chronic, they're already tired. By the time they get to that level of that COPD, they are tired. So it means that their respiratory muscles are not even working fine anymore. They are tired. And the body has acclimatized to that state. So they cannot breathe actively like so it means that the PCO2 in somebody with COPD is going to be high, ideally, because in a stable COPD, they are not hyperventilating. The ventilation is reduced, so PCO2 is always high in them. Now, if we now go and give them excessive supplemental oxygen, so we need to be careful. Because people with COPD can have chronic hypercapnia. They're already used to that hypercapnia. The body has adjusted. In fact, hypercapnia can cause neurologic side effects. It can cause seizures. It can cause confusion, encephalopathy, and all those things. But people with COPD, they don't have it because they are used to it. They are used to it. So we call it chronic hypercapnia. Now, if somebody now comes in and now start bombarding them with oxygen, that's why you have to titrate the supplemental oxygen you give them. If you now go and be giving them oxygen, what oxygen will do is to suppress respiratory drive. So if you now further go and suppress respiratory drive of somebody with COPD, it means that you are going to increase that CO2 beyond normal that they are used to. So that can cause problem. So you don't want to worsen the hypercapnia and cause respiratory acidosis by giving supplemental oxygen. Please, do you understand what I've just explained? Is it clear to us? Okay, I didn't get any response, so I'm assuming that it's clear to us. So people with alpha-1 antitrypsin deficiency suspect that diagnosis in anybody with a family history of COPD that is not a smoker. You are not smoking. You are not having COPD at a very young age, less than 60. Suspect alpha-1 antitrypsin. Now, if they now want to make it clear and obvious, they will tell us that the person is having jaundice, liver problem. And the distribution of the lesion in the COPD is at the base of the lungs. At the base of the lungs. Think about alpha 1 antitrypsin deficiency. So there's a family history because it can be inherited. It's kind of genetic. There is a basilar predominant COPD. This person is having liver disease with no smoking history, alpha 1. Now, the reason why they can have liver disease is because all this what's it called? This the abnormal alpha 1 antitrypsin, they can actually precipitate, they can build up within the liver and they can destroy the liver, causing hepatomegaly. So that's why they usually experience like liver problems, because what brings about alpha 1 antitrypsin deficiency is usually like a mutation in that gene. So when there's a mutation in that gene, the protein that is produced is going to be mutant, is going to be abnormal. So it will start misfolding. So those misfolded alpha 1 antitrypsin protein, they will accumulate in the liver and they can cause liver damage. So that's why we call it alpha 1 antitrypsin deficiency. So now, what are the subtypes? We have talked about it: emphysema, chronic bronchitis. And we have said that chronic bronchitis is a what? Is a clinical diagnosis. This guy is a pathologic diagnosis. This one, there's going to be damage to the alveoli usually because of destruction of the elastic fibers within the alveoli from neutrophilic elastase. This one is just mucus clogging the airway, like the bronchial. You look at the name, bronchitis, not alveolitis, bronchitis. So it means that the inflammation is confined majorly to the bronchial airway. It does not usually affect the alveoli. So we have talked about the definition. We have talked about the definition for chronic bronchitis too. People with chronic bronchitis, they call them blue bloaters. They call them blue bloaters. Why? Because they experience early hypercapnia and early hypoxia. So these people don't really do much work. Their airways are already obstructed. There's little they can do. Mucus is everywhere. So that kind of allows oxygen, like that kind of create like a resistance for oxygen to flow through the bronchial airways into the alveoli. So there is a form of hypoxemia happening. And we remember, when oxygen is deficient in the pulmonary vasculature, it will cause what? What is it going to cause to the pulmonary vasculature? Anybody from our step 1? Is it going to be vasoconstriction or vasodilation? If
Vasoconstriction.
so there's going to be vasoconstriction. So just imagine that there's a pulmonary vasoconstriction. What do we think will happen to the afterload in the right ventricle? It's going to be increased. So that means that fluid is going to pull up in the right ventricle, they'll pull up in the right atrium, and from there they will go to the body. So the person is going to appear edematous and overweight because of fluid buildup. So they tend to experience early hypercapnia and hypoxia. Now, people with emphysema, they are called pink puffer because this guy, they have an adjustment mechanism. I don't know. I've seen somebody that has emphysema recently, and I was able to identify this person because of the way the person was breathing. They have this pulse lip. You see them, they will do their mouth in a pulse lip, like they'll kind of, as if they want to kiss somebody. They'll protrude that mouth like this, that is pulse lip. And they are doing that because they want to reduce the airway resistance so that air can easily go out during expiration. But they exert a lot of energy because you're only seeing them, panting. You will see that respiratory distress. The pulse leaping. So all those things consume a lot of energy. So they appear wasted. They don't look overweight or edematous like chronic bronchitis. They appear wasted and thin. And because of this adjustment, they will not have early hypoxia. It's going to be late. So that's why they appear pink initially. But they are dying, but they appear pink. But this chronic bronchitis one, they will appear very blue early. And they start retaining fluid because of pulmonary vasoconstriction. So what are the symptoms? They have a classic barrel chest. If you look at their chest, barrel chest, flat like a barrel. They have, it's very flat, very flat. They look lean, especially the pink puffer, the emphysema. They'll be using the accessory chest muscles. They are going to see jugular vein distension. In which category are we going to see JVD increase? Anybody? In which category is that going to be common?
Core pulmonary. Okay. Doesn't have core
From these two subtypes that we have talked about, which one is going to have JVD distension?
Chronic
Chronic
bronchitis.
Chronic bronchitis.
There's no catch. Chronic bronchitis. They are going to be having JVD. That's a potential question. So people will be confused that first aid did not say it now. You know, once you understand the pathophysiology, you can maneuver yourself through any situation. You know, JVD, chronic bronchitis. You know, they can have end respiratory wheezing, dyspnea exertion, and muffled heart sound. So the reason for the muffled heart sound is because of the air trapping. So they have like muffled heart sound. The air trapping is also the cause of the barrel chest that they experience. So don't forget, people with stable COPD, normal COPD, the PCO2 is what? Is elevated. You have explained that already because they are almost all of them, they have respiratory acidosis baseline. That is it. So sometimes if they have exacerbation, we might need to do like a gram stain or sputum culture to look for the trigger. You know, very important. So what are the things that we do to improve survival in people with COPD? You know, give them supplemental oxygen, encourage them to stop smoking. If we don't know anything in COPD, let's pick these two. Let's just be saying it everywhere. Say it to your friends and family. Stop smoking. Give supplemental oxygen. And the third one is pulmonary rehabilitation, which I'm going to talk about. Those are the things that can improve mortality and survival in COPD patients. Encourage them to stop smoking, number one. Give them supplemental oxygen if necessary. And do pulmonary rehabilitation. Pulmonary rehabilitation. How do you make diagnosis? We have talked about this, spirometry. But it is going to show obstructive pattern. Ratio is going to be less than 70%. Fine. But it's not going to be reversible. That means that if we give them SABA, FEV1 is not going to go more than what percent? More than
20%.
no.
12.
It's not going to go more than 12.
12%.
It's not going to go more than 12. And the volume is not going to go more than what?
200.
It's not going to go more than 200.
200.
It's not going to go more than 200. So if they give you 100, somebody that doesn't have understanding will think it has improved. They will go and pick asthma. No. At 100, that is still in keeping with COPD. Very important stuff because it's no more than 200. Now, what do you expect for your RV is increased? TLC increased. Don't forget, it is obstructive. So RV is going to be increased. TLC is going to be increased. FEV1 is going to be decreased. We have said it, obstructive. And in obstructive, FVC can be reduced or what? Can be normal. There's no catch. But where the difference will now be is now when you start doing reversibility. It's not going to be more than 12% and it's not going to be more than 200 mils. Now, what about DLCO? What will happen to DLCO in asthma? Anybody? DLCO in asthma, what happens?
It's increased.
Increased
normal.
or normal?
Or
Thank you.
normal.
Increased or normal. Now, people with COPD, depending on the COPD, that's where they will now wait. That's where exam question will be. They will be confused. For chronic bronchitis, it will be normal. But for emphysema, it's going to be reduced. Why? We remember in emphysema, there's damage to the alveoli. And alveoli is the one that allows for gaseous exchange. If the alveoli is gone, there's no way our DLCO will be able to move from the airway into the blood. There's no way. If this is a blood vessel, this is a blood vessel, this is the respiratory membrane, and this is the alveoli here. This is the alveoli, this is the respiratory membrane, and this one is our blood vessel. If alveoli is gone, collapsed, there's no way CO2, carbon monoxide will pass across. So DLCO will reduce. But in chronic bronchitis, the only problem is just with the narrowing of the bronchial airway. So some of the carbon monoxide can still manage across. In fact, they are diffusion dependent. You know, they're diffusion limited rather. So it means that the only thing that can limit them, all this step one stuff, that's what they mean. Oh. So all those things look complex, but what they are just saying is that what can limit its passage is just when there's impairment of the surface area, diffusion limited. So it means that this obstruction here cannot stop it. It cannot stop it unless there's something affecting the respiratory membrane or the alveoli. So that is why people with chronic bronchitis, DSO is normal. Why people with emphysema, DSO is reduced. Arrow question your exam. Be expecting it. Be expecting. You know what you are looking for. You are not panicking. You have moved. You have saved time. You have other time to be thinking about other important questions rather than be wasting time on COPD and what's it called, emphysema and chronic bronchitis. Okay, so if you do your chest X-ray, what are you going to see? Don't forget hyperinflation. You can see the hyperinflation everywhere is just black. Okay, somebody's raising up their hand.
Yes. Yeah, I wanted you to take that the DLQ, the reduced DLQ. Okay, please, thank you.
They do. So what I'm saying is, now this is the alveoli. This is the bronchial airway. Now it will break into smaller fragments, and this will be the alveoli. This is going to be the respiratory membrane. This is going to be blood vessel. Now, I said that the only thing that can stop carbon monoxide, which is CO, from passing, because it is diffusion limited, is what? Any compromise of diffusion. Maybe there's a damage to the respiratory membrane or the alveoli. The surface area of the alveoli is reduced. And the only way surface area of alveoli can be reduced is when they are collapsed. So those are the two things. Now, in somebody with chronic bronchitis, they just have mucus occluding the bronchial airways. But just picture it that carbon monoxide will still be able to squeeze itself through. Because carbon monoxide can easily, it has a very high tendency to diffuse. So once you introduce it, it will be able to pass across, move through the alveoli, move through the respiratory membrane, and get to the blood. So that's why in people with chronic bronchitis, DSO is normal. Do you understand that, Doc? Do you get that?
Yes, thank you. Yes.
Okay, like I can proceed now. You get the OGs now, right?
Yes, thank you
Okay,
so much.
okay, you are welcome. So if you do the chest X-ray, what are you going to see? Hyperinflation. Everywhere is going to look black. If you look at the mediastinum, it's going to be narrow. Look at this mediastinum. Narrow mediastinum. Hyperinflated lung fields. Reduced lung marking, because everything that is air that is in this setting is air. You cannot see any lung marking. The lung parenchyma is kind of occluded. You cannot see lung marking because of too much air. And when there's too much air in a area, there's going to be a high tendency for the person to be forming bullae. Bullae and blebs, they are just like collection of hair in pockets. So they'll be having parenchyma, bullae, and bleb. And the risk when somebody is having bullae and blebs is what? Anybody knows? If somebody is having blebs and bullae, what are they at risk of having? Anybody?
Obtaining pneumothorax.
Pneumothorax.
Yeah.
They'll just be having pneumothorax. So don't be surprised when they are saying risk factor for pneumothorax is COPD. It is as simple as that.
Like, did you say hemo or pneumothorax?
Pneumothorax. So, moving on to the treatment. So, how do we treat somebody that comes to us with somebody's raising up their hands? Sorry, I cannot see the background stuff. So
sorry to interrupt you, just to check if you're recording.
Okay, yes, I'm recording. The last time it was actually recording, but the icon changed, to this part. So I thought I was not recording, but I was. Yeah. Thank you, doctor, for that. I really appreciate it. Please check out, help me. You can help me, check it from time to time so that we are safe. I'm so sorry. Thank you so much for that. So, for the treatment, how do we treat them? They came in with acute exacerbation. How do you want to treat? It's just very similar to asthma. Check their oxygen saturation. Is it less than 88? If it's less than 88, please give them oxygen and titrate it. Look at the word. Titrate it to what? 82, 88 to 92. Don't take it beyond 92. Because of what? Anybody knows why we don't want to take it beyond 92? What's the word? Because we want to avoid what?
Worsening hypercapnia.
You don't want to worsen the hypercapnia. That's it. So leave it between 88 to 92. It is as simple as that. Then you want to reduce the airway resistance, because there's bronchoconstriction, there's airway narrowing already. So give them inhaled bronchodilators. Like you can, just like in asthma, you can give them the SABA usually, or anticholinergics like ipratropium. You can combine both of them. Don't forget, this is not when we'll be giving salmeterol. use albuterol, Saba, something like short acting that can quickly relieve that obstruction. And you give them systemic corticosteroid. So we have to be careful here. In people with asthma, we use inhaled corticosteroids. In COPD, you give them oral. If they can take oral, give it. Oral Pred, oral Met, anyone that's available. If they can't take oral, give them IV corticosteroids. That's what you do in COPD. Now, to now decide if you are going to add antibiotics or not, you need to look at three things. Are they having difficulty in breathing? Are they having increased coughing? Okay, they are coughing. Is it productive with sputum? If any two of this is present, add antibiotics because it's likely to be from an infection. Are they dyspneic? Are they coughing? If they are coughing, is it productive? Any two of it, give antibiotics. So don't forget, oxygen, bronchodilators, then steroid. Asthma, inhaled steroid. COPD, oral or intravenous steroid. Then look at, is there any need for antibiotics? Evaluate. If there's a need, give it. If there's no need, don't give it. Now, in exacerbation, sometimes they can have feature of respiratory failure. Don't forget, in asthma, we said respiratory failure when PCO2 is what? Is more than 50. And I also forgot to say, if PO2, which is that of oxygen, is less than 50, some authority will say 60, So, but just keep that in mind. So, but usually, if PaO2 is less than 50, PCO2 is greater than 50, that is respiratory failure. You have to do something active. If the person is having severe hypoxemia, which is evidence of respiratory failure when somebody is having PaO2 less than 50, or the person is having respiratory acidosis, which is PaCO2 greater than 50, or the person is having altered mental sensorium, the person is confused. In that situation, you call that severe exacerbation. So that is not the time you are going to be stopping at this alone. You are not going to stop at this. You are going to go on to consider for NPPV. And the one you are even doing is BiPAP, not even CPAP. BiPAP. Delivering positive pressure in both phase, expiration, inspiration, expiration, inflation. Both of them positive pressure. But if this guy has a risk of aspiration due to what? Confusion, altered sensorium, you cannot use NIPPV. If the person is having increased secretion that can easily aspirate, you cannot use NIPPV. If the person is having facial trauma or burn that you cannot apply the max for the BiPAP, you cannot do NIPPV. So if the person is having increased rate of aspiration due to altered mental status, the person is having increased secretion, facial trauma, just go and do what? Intubation immediately. Or if you have tried NIPPV and it fails, proceed to intubate that patient. That is all about acute exacerbation of COPD. Moving to chronic COPD. So somebody comes to us, just tell us that, doctor, I just feel I'm coughing and it is productive. There's fever. How long have you been coughing? I've been coughing for 3 months, over 2 years, chronic bronchitis. If they tell us I'm coughing, but it's not productive, but I feel very tired, I cannot walk from here to here. And you listen to the heart, you are not picking S3. You are not picking, there's nothing that indicates like heart failure. That's likely going to be emphysema. It is likely going to be, because in emphysema, it is not usually productive. It is chronic bronchitis that is due to mucus that is productive. Don't forget the pathophysiology of emphysema. It is what? Alveolar destruction, not mucus. So it is not going to be productive. But they will tell you that they are having dyspnea and exertion. They cannot walk. They are tired. They used to walk from maybe the front of their house to one mango tree before, but they cannot even walk. They cannot even stand up from their bed to their toilet anymore. They're getting very tired. COPD. So if that is chronic, there's no acute exacerbation. They are not telling us that they are like having like difficulty in breathing, coughing, altered sensorium, and all those things. So that is not acute. Just like in their stable condition, they are kind of like not feeling too strong. So we can call that like chronic stable COPD. So in all those kind of people, you can still offer them treatment, and what you are going to give them is what we call the gold criteria, which I'm going. So we discard everything that is here. This is outdated. We're not going to use that. But before we get to the treatment, what are the modifications you want to even do. Somebody that comes to the hospital, you are seeing the person in the clinic, and you are like, you want to how do I put it now? You want to offer, like, you are not offering like active treatment. You just want to offer something to just modify the lifestyle so that the condition can improve. So the first thing you want to do is just to encourage them to stop taking smoke. Don't smoke. Don't smoke. The next thing is to vaccinate. Don't ever forget it. You cannot. It's not possible to forget it. Vaccinate them. Pneumococcal vaccine, influenza vaccine. So they take this annually. They take influenza vaccine annually. Then they take pneumococcal vaccine too. So you have to give. So in the US, 13 is no longer available. Delete it. This is gone. So the one we have now is 15, 20. There's 21 now. So for 15, if you are giving 15, we give them 15 first. Then later, after 1 year, you give them the PPSV 23. Very important stuff. Forget it at your own risk. Just like Dr. Festus will say. I'm just begging us, don't forget it. So I'm not going to say forget it. Don't forget it. Don't ever forget it. PCV 15, you come back 1 year. You wait for 1 year. Wait for that 1 year and give them PPSV 23. They need it. They need it. So encourage them to take influenza vaccine annually, provided that the person is more than 6 months. The only contraindication to influenza is if you are not up to 6 months. If you are up to 6 months, COPD, of course, this is a condition of adult people. So all of them must get influenza vaccine annually. And of course, they have to use some of these drugs to feel better, even though they don't have acute exacerbation. They need it, to feel better, and some of them might be on oxygen. So you see some people, they're always carrying oxygen masks everywhere. They're carrying something that they are wearing masks. What they are using is long-term oxygen therapy because of COPD, because of chronic COPD. So what is the indication for this long-term oxygen therapy? Don't forget, we have said it. What reduces mortality is what? Stopping smoking and oxygen therapy. And the last one is pulmonary rehabilitation that we're going to get to very soon. So what are the indications for this long-term oxygen therapy? Are you having like chronic COPD, not acute exacerbation, no, chronic COPD, and your SpO2 is less than 88 or 88? So if it's 88 or less, give them long. They will take it home. They'll be using it at home. They will have given them specified hour. Maybe use like 2-3 hours every morning. They would be on that oxygen therapy. Or that is for SpO2 if it's less than 88 or 88. Or if the PaO2 is at level of 55 or less, they have to use it. The only people that you have a higher threshold, no, you have a lower threshold to give oxygen is people that have feature of like hypoxemia already happening. For example, someone that's having polycythemia. One of the causes of polycythemia in COPD is that hypoxemia. Hypoxemia can drive erythropoietin, that will be causing polycythemia. Hypoxemia can cause right heart failure. I will answer the question now. Hypoxemia can cause right heart failure. We have explained it when we are talking about blue bloaters in chronic bronchitis. The hypoxemia will increase pulmonary vascular resistance, and the person is going to be having right heart failure. Hypoxemia can cause pulmonary, meaning somebody is having right heart failure from a pulmonary cause. That is pulmonary. The pulmonary cause here is COPD. So anybody having right heart failure, polycythemia, you don't wait it to get to 88. Once it's at 89 or less, go and give them oxygen therapy. And if the PaO2, you don't wait to 55. If it's at 59 or less, go and give them oxygen therapy. And don't forget you want to titrate because supplemental oxygen can worsen their hypercapnia. Somebody wants to ask the question.
Yes, please, sir. Can you please differentiate between SpO2 and PaO2 for me? Thank you.
The SpO2 is the one that we measure with our oxygen saturation, that pulse oximeter that we attach. So that's like the amount of oxygen that is combined to hemoglobin. That's saturation. That is saturated with the amount of hemoglobin that is saturated with oxygen. SpO2. Now, PaO2 is the one that is dissolved in blood. So that one, we can only measure it with doing our arterial blood gas. Well, I don't think we do it in Nigeria. I don't know. So it's not something we can get quickly, ABG. So you have to go and check the what's it called, the amount of oxygen that is dissolved in the blood. That's the PaO2. That's the partial pressure, because that's the one that is exerting pressure. The oxygen that is bound to hemoglobin, it doesn't exert any pressure. But the one that is dissolved, that is flowing, that's the one that can exert pressure. So that's why they call it like PO2. So the partial pressure of oxygen in the blood. So do you understand that, Doc? So you
Yes,
measure
thank you.
that by doing your arterial blood gas. Yes. So measure lactate, PO2, PaCO2, and all those things. Yeah. Okay. So stop smoking. Go and take influenza vaccine. Go and take pneumococcal vaccine. Take your PCV15 now. Come back after 1 year to take your PPSV23. Right? Now, if the person is having chronic hypoxemia, consider for oxygen therapy. Less than 88, less than 88%, less than 55 mmHg. Or if the person is having polycythemia, or the person is having right heart failure, you have a lower threshold. So if it's less than 89 or less than 59 for mmHg, that's a PO2. That's when you give oxygen. Don't forget all this. Please, let us scribble it somewhere in our note and have it spinal level. It has to be with us in our exam. Because once you forget it, no problem. So don't let us forget it. So pulmonary rehabilitation. So this is just more like a program that we organize for the patient. And what are we doing in pulmonary rehabilitation? We are encouraging them to be doing breathing exercise, so that all those respiratory muscles, they will not be deconditioned. They will be up again. They will not be fatigued. You are encouraging nutritional rehabilitation, giving them food, nutritional food, protein, carbs. Because many people with COPD, they are wasted. Please eat, eat so that you can recover. People that have COPD, they are cachectic, they are wasted. Take food, nutritional rehabilitation. Counseling, you take them to all those groups, that people that are fellow smokers, they can come together and they can be discussing, how are we going to go about our life? They said that we need to stop smoking. Do you have any strategy? They communicate, they interact. We do like motivational interviewing for them. Please stop smoking. You guys should discuss among yourself. Smoking is bad. So when they see people with the same condition, they would be encouraged to want to quit. So the also you also teach them techniques to use the inhalers, techniques to use inhalers and all those things. So smoking cessation, treat comorbidity. Maybe you have diabetes, encourage what's it called, regular clinic visits, encourage the receival of vaccine. So you need to take influenza vaccine, you need to take pneumococcal. So those are all those things you do under pulmonary rehabilitation. So if you want to give them, so somebody with not exacerbation, just normal chronic COPD, you want to give them drugs. So what you do is you use the GOLD criteria, and I have it here. The GOLD algorithm is here, and so this is what we do. We group them into group A, B, E. Before it used to be group A, B, C, D or so. So they've stopped, they canceled that. So it's now E, A, and B. So now if you take history and the person has had one hospitalization before, automatically the person is going to fall under group E. Or if the person has not been hospitalized, but the person has had 2 or more exacerbation before, place them under group E. Now, if somebody has had only one exacerbation, or the person has not been hospitalized before, so the person is not going to fall under group E. It's going to be between group A and B. Now, what is going to differentiate them is the CAT score, but we don't need that. If they want us to do this, they are going to give us that CAT score. We cannot calculate it. So if the CAT score is equal or greater than 10, the person is going to fall under group B. If it's less than 10, the person is going to fall under group A. So people group A, you give them either LABA or LAMA. You have to choose one. Either LABA, but me, I would say LABA. People in group B and group E, you have to combine. You must combine LABA plus LAMA, LABA plus LAMA. And you might want to introduce inhaled corticosteroid for anybody with eosinophil count more than 300. Eosinophil count more than 300 is a lot. So give ICS to reduce the eosinophil count and reduce the inflammation. So that is the algorithm, for treating like stable COPD. So moving on, I think I have one or two questions. This is 4 o'clock. For this, okay, this 3:30. So we spend like 2 hours. So we'll go for a break. Let's just see one or two questions. I'm so sorry. Let me look for. I think I should have. So let us look at this quickly. Let's look at this. A 71-year-old man with severe COPD comes to the office due to worsening exertional dyspnea and fatigue. The patient takes a combination of Vilantrol, something dinyl-butyrylazole as prescribed, but becomes winded with light activity, such as when tying his shoes, taking a shower, and cooking. He is reluctant to perform minimal exertion because it provokes his dyspnea, triggers anxiety, and leaves him feeling wiped out for the remainder of the day. The patient reports daily cough but minimal sputum production. He has required outpatient antibiotics and oral corticosteroid on 2 occasions for acute exacerbation. A recent low-dose screening CT scan of the chest show extensive emphysema and hyperinflation with no suspicious nodule. The patient has a 60-pack year history but quit smoking 10 years ago. Vitals are normal. BMI is 19. After walking for 6 minutes at the usual pace, oxygen saturation in room here is 92. Which of following is most strongly indicated to improve the patient's ability to perform daily activity and reduces risk of COPD-related hospitalization? Anybody? Please, let's read the question. Anybody? Are we still here or is my network?
We are here.
We're reading here.
Pulmonary rehabilitation.
Pulmonary rehabilitation. So why are we not giving this guy continuous oxygen?
His SpO2 is 92%.
The SpO2 is 92%. So we cannot consider a continuous
Long
oxygen.
time.
Yes, we cannot consider long-term oxygen. So that's what we have to consider. Not just that we just sit and we just jump that, we have said oxygen, just go and pick oxygen, you will see oxygen. So we have to be careful. This guy is 92, he's doing well. So there's no need for oxygen. If it's 88 now, we can give oxygen.
But why is it not A?
Chest physiotherapy. What does chest physiotherapy wants to do? Chest physiotherapy cannot do anything, and this guy is not even having cough that is even productive. So why do you want to do chest physiotherapy?
Okay.
If this guy was having bronchiectasis now, we might have considered chest physiotherapy. But if you look at the question, they said reduce his risk, of COPD-related hospitalization. So that is another thing they're asking. It's more like relating to like mortality and the likes. So, but if this is bronchiectasis now, you can consider like chest physiotherapy.
Sorry, I have a question. So, what's the difference in chest physiotherapy and rehab? Like, what would they do? What does it involve?
Yeah, so chest physiotherapy is under rehab. It's under rehab too, especially for people with chronic bronchitis because they produce a lot of mucus. So, and chest physiotherapy also is going to help them with the deconditioning of the muscles. People with COPD, the muscles are very frail. So you can like encourage some chest exercise, just to keep the muscles up and the likes. And yeah, that's majorly about chest physiotherapy. But pulmonary rehabilitation is more encompassing. It talks about chest physiotherapy, talks about them taking their vaccinations, them using their drugs properly, taking a very good lifestyle to get nutrition, to keep themselves healthy and the likes. Do you understand what I'm saying? So pulmonary rehabilitation is
thank
a
you.
much more encompassing term compared to chest physiotherapy. So that is it. All right. So a 68-year-old woman with a history of advanced COPD comes to the emergency department due to increased shortness of breath and cough for 12 hours. He took 2 extra nebulizer at home with no relief of symptoms. He had no fever, nausea, vomiting, hemoptysis. The patient has been oxygen dependent for the past 2 years. She has a 45-year pack smoking history and quit 6 years ago. Medications include tiotropium daily, fluticasone, and albuterol metered inhaler or nebulizer as needed. Vitals is normal. Patient appears dyspneic and in moderate distress. She was given antibiotics, metipred, and 2 treatment of nebulized ipratropium with albuterol. Following these measures, the patient remains dyspneic and uses accessory modes of respiration, but is alert and follows command. On 4 liters of oxygen, pulse oximetry is 89, and arterial blood gas shows pH of 7.3, PCO2 of 63, PO2 of 54, and chest ratio hyperinflation. Which of following is the best next step in the management of this patient?
Start NIPPV.
Start NIPPV. Why? Why do you want to start NIPPV? Why don't you want to intubate this patient?
One, the PCO2 is greater than 50, PO2 is 54. So you want to consider NIPPV, and there's no contraindication to NIPPV.
Yeah, this guy is.
Patient is alert.
The patient is alert and follows
Yeah.
command. So try NIPP first before you intubate and do. Okay, so that's that. That's that. Okay, so moving on to the. Okay, let's take a break. Let's take a break. 15 minutes. We'll come back in 15 minutes, please. Hello. So would continue with the restrictive lung disease. So we know that the restrictive lung disease are usually characterized by loss of lung compliance. So the lungs find it very difficult to expand, and there's something I'm going to talk about with respect to the compliance of the COPD that I explained initially. There's something we need to revise there. So people with restrictive lung disease, they have a drop in the lung compliance because of the lung stiffness, and the lung is not easily expand. So most of the causes of restrictive lung disease is fibrosis most of the time, but it's more than that. It could be from okay, so we are going to use this acronym just to remember everything, and that's the HANT. So HANT is for alveolar problem. Maybe there's alveolar edema, there's blood, there's pus in the alveoli, maybe from pulmonary hemorrhage or something. It could be from interstitial lung disease, that's the high of the HANT. So high interstitial lung disease. So that's the one that we commonly know. So stuff like pulmonary fibrosis, sarcoidosis with interstitial pneumonia, chronic hypersensitivity pneumonitis. The N is for neuromuscular problems. So people with myasthenia gravis, phrenic nerve palsy, any cause of myopathy, Duchenne, polymyositis, they can be like neuromuscular causes of restrictive lung disease, because in all these things there's paralysis of the respiratory muscles. So it's very difficult for the chest wall to expand for air to come into the airway. So that's why neuromuscular problems can cause restrictive lung disease. Then the last is a T, which is the thoracic wall. So kyphoscoliosis, also impairs expansion of the airway, obesity, too much fat, ascites, pregnancy, ankylosing spondylitis. So, but the one we are talking about in this chapter is basically the interstitial lung disease. So what is common to all of them is inflammation and fibrosis of the interstitium. So that's like the lung parenchyma. So when there's inflammation and fibrosis of the lung parenchyma, you have interstitial lung disease. And it can be categorized into three group. The first one is the idiopathic one. We don't know the cause. So we have idiopathic pulmonary fibrosis, we have cryptogenic organizing pneumonia. So these two fall under the idiopathic cause of ILD. And we have the ones associated with systemic disease or connective tissue disease. So okay, yeah. So the one associated with systemic disease or connective tissue disease like polymyositis, dermatomyositis, sarcoidosis, amyloidosis. So all these things can cause interstitial lung disease too. Somebody can have polymyositis and have interstitial lung disease. So amyloidosis can cause interstitial lung disease, sarcoidosis too, scleroderma, and any cause of vasculitis that you can think of. Then the last one is the exposure related. So this one is the commonest one that we know. So either they're exposed to some dust like asbestos, silica dust, beryllium, coal, or they are exposed to some toxic agents. Like it could be even be animal dungs, like the bed fancier, disease. They can have hypersensitivity pneumonitis, and when it becomes chronic, they can have ILD from there. It could be medication like amiodarone or bleomycin. They could cause ILD and radiation. So one thing I just want us to speak here is that all these things that we have mentioned, they are going to cause fibrosis. Somebody can have exposure to all these things and develop fibrosis of the lungs. Somebody can have sarcoidosis, dermatomyositis, polymyositis, scleroderma, and they can have fibrosis of the lungs. And somebody can have that fibrosis from idiopathic causes that you don't even know where it's from. So we need to be familiar with some of those medications. BAN, band radiation. So B for Borsafan, bleomycin, A for amiodarone, N for nitrofurantoin, and R for radiation. So these are the commonest drugs they can ask us. So methotrexate is also inclusive. So Borsafan, bleomycin, amiodarone, nitrofurantoin, methotrexate, and radiation. Even high long-term oxygen, can cause ILD. So what in the history are we going to see that should raise our suspicion for ILD? So if they tell us that somebody is having dyspnea and the person is also having cough, so somebody is having dyspnea on exertion, number one, and the person is having cough that is non-productive, with rapid shallow breathing until otherwise proven, your diagnosis is going to be interstitial lung disease. Now, there is an algorithm, there is a formula for ventilation, and ventilation equals respiratory rate times tidal volume from our step 1 recipe. Dr. Babandi will have mentioned this. So tidal volume times respiratory rate. Now, people with ILD, permit me just to use the acronym, ILD. People with ILD, there's a problem of expansion. There's a problem of compliance. There's no space for the lung to expand because the lung is fibrotic. So if this is somebody's normal lung, this is going to be the lung of somebody with ILD. It's going to be shrinking. It means that this volume already is reduced. So this lung has a very little capacity for tidal volume, because the volume is already reduced. So if I want to increase ventilation in this person, it's best for me to increase respiratory rate because there's little I can do to the tidal volume. So that is why people with ILD, what they engage in is to do what? A shallow, rapid breathing. So if you look at it, if you increase respiratory rate, you have a rapid breathing. if we reduce tidal volume, it's going to be shallow. It will not be deep. So they'll be having, it will be fast, but it's not going to be deep because you cannot take in much air because of the little volume that is available. So the only way they can compensate is to engage in a rapid, shallow. You bring this down and you bring this up. That's the only way you can increase ventilation because this is already down. So increase this to increase this. So what you are seeing, rapid, shallow breathing, dyspnea on exertion, cough that is non-productive. To now nail it, you now hear fine inspiratory crackles. This is all you need to make diagnosis of high LD. You listen to the chest, you are hearing the fine inspiratory crackles until otherwise, not wheezing, crackles until otherwise proven. That is high LD, that is ongoing. Of course, because of the hypoxia, they will be cyanotic. Because of the hypoxia, they are going to be having finger clubbing. Because of the hypoxia, they are going to be having core pulmonale, which is going to lead to right heart failure. To make the diagnosis, we can request for a chest X-ray. As simple as a chest X-ray can help us. And one thing about the chest X-ray is that we are going to be seeing reticulonodular opacities, because this is very classic for when there is fibrosis. So you'll be seeing reticular pattern, reticulonodular. That could be what you are going to see in the question. Or they could say ground glass, fluffy opacity. So once you are saying reticulonodular ground glass pattern, think about interstitial lung disease. There's a problem with that interstitium. The parenchyma of the lung is likely to be fibrosed. To further nail your diagnosis, you want to have a closer look, just like in bronchiectasis. Request for your high resolution CT scan. Now, if you remember, in bronchiectasis, what we are going to see in the CT scan is what? The signet ring appearance, in which you just see that there's going to be abnormal dilatation of the bronchioles compared to the respiratory artery, which will be tiny. And you are going to be seeing some cysts at the distal end of the bronchioles. That's in bronchiectasis. But here, you are going to be seeing honeycombing appearance. So that's just like cysts that are formed due to fibrosis of the lung. So let us see if we have like a very good image. So this one is not a very good image, actually. And it's very surprising that you don't attach a very good image. But this is what it looks like, the honeycombing appearance of, let me see if I can, I'm coming. Honeycomb. Honeycombing. So let us see what it looks like. So it's just multiple cystic spaces. Exactly. So this is it here. So this is what we see. All these stuffs, they look like the comb of honey. If you look at all this nest of honey, this is the way they look like. So this is classic. So you cannot confuse this with bronchiectasis. By the time you look at the history, bronchiectasis is going to be productive. There's going to be copious mucoid production that is going to be, foul smelling, hemoptysis. You will not see that with high LD. So that is a very fast way to delineate them. High LD is not going to be productive. There's nothing to produce. They can have cough, but it's going to be non-productive. This sound exertion, shallow, rapid breathing with crackles. Just go and pick your high LD, and move. So, if we do the pulmonary function test, so what are we going to see? So at this point, what you are going to see is not the obstructive pattern anymore. So it's going to be the restrictive pattern. So, which is an increase ratio more than 70%, or the ratio might just be at 70. It might be normal. So don't be confused. They can just give you at 70. It's still in keeping with the restrictive problem. So, and don't forget, we said it in restrictive, everything drops. Everything drops. FEV, FVC, TLO, FVC, it will drop. Now, this one will drop. But mind you, The DLCO that is dropping is only dropping because the cause of this restrictive lung disease is what? Interstitial lung disease. It's ILD. There's a problem with the parenchyma of the lung. If somebody is having obesity or somebody is having kyphoscoliosis, neuromuscular cause of restrictive lung disease, because the lung parenchyma is not involved, DLCO is going to be normal. But if you do your pulmonary function test, you are going to get all these other patterns. Do we understand what I've said? Is it clear to us? Please, I need response.
Yes.
Yeah, okay, thank you. So that is very important to take note of. Now, how do you investigate? We have talked about the causes. We talk about the exposure. So is this person working as a mechanic, electrician? Do you work in aerospace? Are you a coal miner? Do you work in foundries? Those are the causes of silicosis, berylosis, and all those things. That's exposure. We talk about the vasculitis. We talked about the what's it called? The polymyositis, dermatomyositis, right? The systemic problems. We check for CK and Adolis. Is it elevated to rule out all those ones? We talked about sarcoidosis. We'll have seen that on X-ray already. We'll have picked it on X-ray. We talked about amyloidosis. We do our Congo red staining. Any biopsy we are taking. We talked about other vasculitis too. We talked about, what other one did we say can be, because it's a lot, but which one have we not mentioned? I think we mentioned everything except scleroderma. So, that's the way you investigate. Just investigate along the line of the potential cause based on the history of that patient. But the most accurate test would be to do a surgical biopsy, but you will not get to this, So don't forget your X-ray with your high resolution CT scan. That's the gold standard. You have to do this CT scan to be able to see what is there. And don't forget the velcro-like or the fine inspiratory crackles. The fine velcro-like crackles that you hear is classic for ILD. So the treatment is supportive. Just avoid exposure. So if this person is having asbestosis, berylosis, reduce the exposure to all those things. If the person is having idiopathic pulmonary fibrosis, you have to give steroid. You have to give antifibrotic agent like pirfenidone or Nintendo. Nintendo, for some of us that play game, Nintendo, Nintendo, or pirfenidone. They are antifibrotic agent and they are usually used for IPF, idiopathic. For the other ones, just give them steroid. Example, somebody with chronic hypersensitivity pneumonitis, you can give them steroid. If you don't see avoidance of, causative agent there, just pick steroid. If it's idiopathic, and you don't see steroid, give antifibrotic like Nintedanib or pirfenidone. Then the later stage, they should get the lung transplanted. Of course, if the lung is fibrotic, that's a chronic process. There's nothing we can do to bring it back. So if it's very bad, the best thing is just to go for a lung transplantation. Let me see what question we have here. So, a 65-year-old man is brought to the physician due to 6 months of dry cough and worsening dyspnea. He's coughing for 6 months and it's dry, worsening dyspnea. Her dyspnea has progressed so that she is now able to walk only a few steps. She has no fever, no chest pain, no hemoptysis. What are they trying to rule out for us there? No fever, no chest pain, hemoptysis. Anybody? What have they ruled out for us? Anybody knows? Fever, chest pain, hemoptysis. What could it be?
TB.
Huh?
TB can cause hemoptysis and fever.
That could be TB, exactly. That could be bronchitis ruled out already in a way. So they said it's dry, no fever, no hemoptysis. You cannot be thinking of bronchitis anymore. Our only medication is Thiazide for hypertension. The patient is a retired school teacher and she does not use tobacco or alcohol. She has no pet and she has never traveled abroad. Temperature is 37.2, blood pressure is 140, pulse is normal, Chest examination shows a dry, late inspiratory crackles and digital clubbing. There's no peripheral edema. Serology is negative for ANA and ANCA. Chest X-ray shows diffuse reticular opacity. A high resolution CT scan is shown. Do I have the CT scan? Oh my God. I don't think we need it. Which of the following abnormalities is most likely present in this patient? Anybody? Let me see.
Increased alveolar arterial gradient.
Okay, I'm coming on. So sorry. I think I have it. Just to show us. Yeah. So this is the honeycomb bean appearance of the ILD. So let's go back. Yes. So what's our answer? Increased alveolar gradient. So can we just eliminate them? Decreased FEV ratio. Why are we not picking that?
That's an obstructive.
That's an obstructive pattern. Exactly. Increased diffusion capacity for CO. What do we expect?
Decreased.
It should be decreased.
Decreased.
Increased PaCO2. What do we expect? Is it now increased PaCO2? Which one is this one for?
That should be obstructive.
That should be obstructive. Thank you. Increased residual volume. That one too is obstructive. So the only make sense answer here, even if we have not even done it, is increased alveolar gradient. And we are going to talk about it shortly. A 62-year-old man comes to the office due to a year of progressive exertional dyspnea and dry cough. He lives by himself and he has been having difficulty performing activities. The patient has a history of reflux and osteoarthritis. He smoked a pack of cigarettes daily for 40 years and occasionally drinks alcohol. The patient worked as a carpenter for 20 years and before that, he repaired Navy ships. He has no pets and or has a travel history. Blood pressure is this, blah blah blah. Just said, okay, I think we have not done this. We'll go back. I know we know it, but let's go back and talk about it first. We'll come back to the question. So sorry, I didn't know that the arrangement was a little bit faulty. Now, that's why I don't like bolding this thing. I'll be able to close it. Okay. So I think we get the gist for interstitial lung disease. But let's just have it like that. It will not go beyond that. Trust me. They won't ask you beyond that. So cryptogenic organizing pneumonia. So this is just a form of pneumonia that is associated with formation of buds of granulation tissue. We call them the Mason bodies. They are just like buds of granulation tissue forming in the alveoli. That is it. So we don't know the cause. It's very common in people within the age of like 40 to 50 years. Just see them having those buds of granulation tissue forming in their lungs. And they can be presenting like pneumonia. So they will have a presentation that's very similar to pneumonia. But how you are going to know that it is not pneumonia is now when you start giving them antibiotics and they are not responding. So somebody comes to us, person is complaining of fever, dry cough, shortness of breath, weight loss, anorexia, and malaria. So they're looking at, okay, maybe this person has pneumonia. I will now give antibiotics because of the fever. And the person doesn't respond. We have a high index of suspicion for COP. So, but before you can nail COP, because this is like an idiopathic cause, so it has to be like you must have ruled out other, you must have ruled out other potential causes of that presentation. And one potential cause is pneumonia that we have talked about. So you have to do a bronchoalveolar lavage to take sputum and lavage the bronchial secretions and culture them, gram stain, and check if there's any infection before you can say that this is COP. It's a diagnosis of exclusion. You must have excluded the potential, causes of that presentation. And one thing again that we are going to see on imaging is going to be the bilateral peripheral patchy opacity that will be fleeting. They will be migrating. So you see opacity in one side of the lung now. Tomorrow when you come back, you see it on that part. So it's moving from one part to another part. That is COP for you. So of course, it's going to show a restrictive defect. The only thing you need to ask yourself, a restrictive defect with diffusion impairment. And the diffusion impairment they are talking about, how are we going to know there's diffusion impairment? Anybody? How are we going to know? Anybody?
The DLCO will
The
be low.
DLCO2, no catch. We just go and check our DL. That's how we are going to know that there's a problem with diffusion stuff. So they are telling us that there's going to be a restrictive defect with diffusion impairment, meaning that the parenchyma of the lung is affected. That is it. That is just what you need to ask yourself in the exam. Is the parenchyma of the lung affected? Yes or no? If it's affected, go and pick diffusion impairment. DLCO will be low. That is it. So pathology examination is going to show, okay, yeah, that's that. So how do we treat? Now, one thing about it is that when you start giving them steroids, there's going to be a drastic improvement. So the fever, the shortness of breath, the cough, they are going to resolve. And even all the opacities that are, peripheral, they will disappear. But once you stop the steroid, it goes back. So that's, the clincher for COP. Although the prognosis is very good because it responds to steroids. So moving on to sarcoidosis. Sarcoidosis is one of those very commonly tested condition, and I know we know it. And one thing that is peculiar to sarcoidosis, if we want to talk about sarcoidosis, there's a lot to discuss, but we'll just make it simple. The problem here is the formation of granulomas. Just like we have talked about granulomas in leprosy and tuberculosis. Here, there is granuloma too. And the granuloma is going to be non-syssating. It will not be syssating like that of TB. Why? Because this is not caused by infection. That's the only thing you need to know. Once it is not caused by infection, don't go and pick syssating. It will not be syssating. It will be non-syssating. There's nothing to form the caseous necrosis. No infection. So it's very common in the females, people from North European, all these people from Turkey and the likes, and African people sometimes. How would they present? They will just have like constitutional symptoms, usually fever, because of affectation of the lungs, cough, dyspnea, malaise, weight loss, and arthritis. Nothing specific really. But by the time we start doing our chest X-ray, we are going to see some clinchers that's going to increase our suspicion for sarcoidosis. And the first thing is that there's going to be like bilateral hilar adenopathy. There's going to be bilateral hilar adenopathy. Bilateral hilar adenopathy. So I think this might be an image for a question. So this is the adenopathy here. You can see this, bilateral hilar adenopathy, is specific for sarcoidosis. And again, they are going to be having reticular opacity in the upper lobe of the chest X-ray. So by the time we do the chest X-ray, we are going to be seeing reticular opacity. Don't forget, we have said that the umbrella term, for most of all these interstitial lung diseases is what? Reticulonodular pattern or ground glass opacity. So sarcoidosis too is going to be having reticular opacity, and it can be nodular too. Reticulonodular opacity, but preferentially affecting the upper lobe. Don't forget it. It affects preferentially the upper lobe. So after you have done the chest X-ray and we have seen that we have to do a high resolution CT. So before I jump, there's something called the Lofgren phenomenon or Lofgren syndrome, and that is like cluster of symptoms for sarcoidosis that I coined from the word, like I just gave it the acronym FAME. So F for the fever that they experience. So there's a fever, the A for the adenopathy, the A for the adenopathy. So they have the bilateral hilar adenopathy, the M for the migratory polyarthralgia, and the E for the erythema nodosum. So they have erythema nodosum, E, they have migratory polyarthralgia, they have bilateral adenopathy, and they have fever. Lofgren syndrome. So what are the other extrapulmonary manifestations that they can experience? Right. So because this is a condition that's associated with formation of non-syssating granuloma. So they can have granuloma formation in the liver. So they have hepatomegaly. They can have uveitis. In the skin, they can have erythema nodosum. Everybody knows erythema nodosum here in dermatology. They can have some skin lesion that we call lupus penile. Oh my God, I attached it to lupus penile is here. I know that I attached it. So you see this, they can show us this in our exam. Some people go and rush to pick SLE, they will not read the question. So this is very similar to people with SLE. This is very similar to what they have, but this is not SLE. So lupus penile, looks like the malar rash for SLE. This is seen in sarcoidosis. So the only way you can differentiate them is when you look at the other symptoms. That's the only way you can differentiate that. Oh, this is not actually SLE. You can see the, hilar lymphadenopathy. Yeah, bilateral hilar lymphadenopathy. So it can affect the CNS. So they can have diabetes insipidus. They can have hypopituitarism. They can have facial nerve palsy. Those are the CNS problem that they can have facial nerve palsy. They can have hypopituitarism. They can have central DI. So they can paint a scenario of somebody with central DI and ask us what the cause. Some people will see sarcoidosis, they will strike it out. They will say, no, I've not heard of it before. We have heard of it now. Sarcoidosis can cause central DI. It's not neurologic complications. They can have third-degree heart block on the heart. They can have kidney problems. They can have nephrocalcinosis. They can have nephrolithiasis. The problem is that people with sarcoidosis usually have, because they have a lot of granuloma. They have a lot of granuloma being formed. A lot of granuloma. The epithelial cells from our step 1 forms the granuloma and they release 1-alpha hydroxylase. We remember that enzyme, 1-alpha hydroxylase. So this is going to be a paraneoplastic manifestation of sarcoidosis. So the 1-alpha hydroxylase is going to lead to excessive production of 1,2,5-dihydroxycholecalciferol, which is vitamin D3. So because of that vitamin D3, there's a lot of calcium. So that's why one of the laboratory features of SAC is going to be what? Hypercalcemia. A lot of calcium, hypercalcemia. So they have a lot of calcium. This calcium can be depositing in the kidneys. So they can have chronic renal failure from hyper, deposition of calcium in the tubules of the kidney. So they can have nephrocalcinosis, they can have stones, they can have kidney stones. What do you call kidney stone again? What's the name again? Nephrolithiasis. Thank you. I just forgot it. Nephrolithiasis, nephrocalcinosis, can come from sarcoidosis because of all these things we have explained. And 1-alpha hydroxylase, and the likes. So we should not forget that. So don't forget the best initial test. You want to do a chest X-ray first. That's the one you select. You see the hilar adenopathy, and we see the reticular opacities too in the upper lobe preferentially. And we can now further confirm by doing a CT, and doing a bronchoscopic biopsy afterwards. So if you do the biopsy, we are going to be seeing the non-cystating granulomas on biopsy. And don't forget, if we do a pulmonary function test, we are going to see the restrictive pattern with a reduced DFCO. You can see that we don't need to cram anything. As they bring it, we will tell them what they will find there because we understand what is happening. So these are the features, the non-cystating granulomas. They can have arthritis. Don't forget, Loeffler syndrome, FAME, fever, adenopathy, bilateral adenopathy, migrating, polyarthritis, and the erythema nodosum. They can have uveitis, erythema nodosum, bilateral hilar adenopathy, interstitial fibrosis of the lungs, negative tuberculosis test. Why? Because this thing is looking at TB now. It can be like TB. All those chest X-ray finding and the likes. But and the granulomas everywhere, but if you do like a TB test, it's going to be negative. So don't be confused that this is tuberculosis. And they have gamma globulinemia. So if we check the level of IgG, it is usually elevated. So don't forget, they have elevated IgG. So this can come in form of arrow question. Arrow question, we know what to pick. USMLE, they like a lot of arrow questions to save themselves headache and to confuse people. So what are the other findings? ACE level, still because of the granulomas. The granulomas will release 1-alpha-hydroxylase. They also at the same time release ACE enzyme. They can have hypercalcemia, which you have explained, hypercalciuria, which you have explained. Because of damage to the liver, there could be elevation of GGT, elevation of AST, elevation of alkaline phosphatase. So don't be surprised. They can have bone marrow issues, lymphopenia. They can have cranial nerve defect. And I gave example. Which cranial nerve did we say?
7.
Cranial nerve 7, facial nerve palsy. They can have third-degree heart block, arrhythmias. Don't forget. They can have central diabetes insipidus. They can have hypopituitarism, neurologic manifestation of sarcoidosis. What do you do if this patient is symptomatic and the person has SAC? Observe. Don't do anything. But if the person has symptoms, or you are seeing lab values like hypercalcemia and all those things, you can go ahead and give steroid. But if the person is asymptomatic and okay, you just did chest X-ray and you see adenopathy, restrictive, and we are seeing reticulonodular opacity in the lung, and the patient is not coughing, not having anything, please don't treat. Observe. You only treat if the patient is symptomatic. Very, very important stuff. Please don't forget. So, if it's refractory, is not responding to steroid, you can now try it, like all those DMARD stuff, methotrexate and TNF. Those are things you try, methotrexate and TNF. So, but Lovegren is very, very benign. So the fame, anybody with fame, just give them NSAID, they're going to be all right. It's very good, benign. So let me see if I have a question. I think I have a question here. So a 38-year-old woman comes to the office due to dry cough and malaria for the past 2 months. She has no prior medical issues. She takes no medication, and the patient reports no allergy, and she does not smoke. Vitals are okay. Examination shows no normality. Her chest X-ray is as shown below. Which of following is the most likely pathology of the patient's condition? So we have seen the chest X-ray. I've seen the chest X-ray. Okay. Right. So you can see the adenopathy, bilateral adenopathy. So what's going to be our answer?
Chronic granulomatous inflammation.
So what are we going to give this patient?
Steroid.
Yeah. We can give steroid because of the symptoms, the cough and the malaria. Yeah. I agree with you. Okay. So moving on to hypersensitivity pneumonitis. So this is another cause of granulomatous, lung disease. So they have formation of non-circulating granulomas too, but this one is due to environmental exposure. So they have exposed to like farm animals, like cattle, or people that rear all this pigeon and bird. So they get exposed to the bird dungs and the like, so they can develop farmer's lung or bird fancier disease. Because they get exposed to the cattle, the dropping of the cattle, the dropping of the birds, the mold that grows on the farm, and they develop farmer's lung or bird fancier disease. So I want to mention that this is a type 3 hypersensitivity reaction. So it means that the problem is actually coming from the deposition of the the antigen and the antibody in the lungs. That's the cause of the problem. It is type 3, especially for the acute form. For the chronic form, it is type 4. So the chronic form is T-cell mediated. The acute form is, antigen, antibody deposition mediated. So how will they present? They will present exactly like somebody with asthma. So once you see somebody presenting exactly like asthma, and you are doing pulmonary function test, and is in keeping with restrictive defects, you already know what to pick. It's going to be hypersensitivity pneumonitis. Now, it can present like asthma, but they are not going to have wheezing. That's the only one that will be different. So in our first aid here, it's classified based on acute, chronic, subacute. But the thing is, it has been scrapped, but it's still good we know it. The basis of classification right now is if there's evidence of fibrosis or not, which to me is still like in keeping with acute or chronic, because in acute, you are not going to see any fibrosis. In chronic, you are going to see fibrosis. So somebody with acute problem, they will just present with features talking about asthma, like coughing, chest tightness, dyspnea, but they are not going to have wheezing. So we can take history, they will tell us that they were working in the farm, but anytime they get back to the farm, the symptoms come back, and anytime they're out of the farm for like 3 weeks, it stops. That's acute hypersensitivity pneumonitis. So the mainstay of treatment is to stop them from, going exposed to that agent. Don't get exposed to the mold, the dung, the hay, the grain again. That's the only thing that can help them. But if this happened for a long time, recurrently like that, 3 months, there's now fibrosis. There's fibrosis. By the time you do your CT scan, you are seeing the honeycomb bean because of fibrosis and all those things. You know that this is chronic hypersensitivity pneumonitis. So that kind of person, you still want to encourage them to stop getting exposed to the agent, but stopping exposure is not going to do all the stuff. So you might need to add steroids to also slow down the progression, of that inflammation. And by the time you start doing the PFT, the result is going to be different. So in acute, the result is going to be different from chronic. So in acute, chronic, both of them, what is common to both of them is that they might be having feature of restrictive lung disease. The ratio is going to be normal. The FEV1 FVC ratio is going to be normal or increased. FEV1 is going to drop, FVC is going to drop, all those things are going to drop. But in acute, your DLCO is going to be normal. But in chronic, because of the fibrosis, DLCO is going to drop. So DLCO is a very good clincher to separate those problems. So don't forget the treatment. Stop for acute, just stop exposure to inciting agent in acute. In chronic, you want to stop exposure and you want to add steroid. So let's see what we have here. So this is a 34-year-old woman who comes to the hospital because of okay, so this is a 34-year-old woman who comes to the hospital after a day of sudden onset fever, chest tightness, dyspnea, and dry cough. The patient has been hospitalized twice in the past 3 months with similar symptoms. Both times she received antibiotic treatment for pneumonia and the symptoms were resolved within 1 to 2 days. She does not take tobacco, alcohol, or illicit drugs. She has no drug allergies. Temperature is elevated. Blood pressure is 128, pulse is 92, respiration is 20. Pulse oximetry is 90%. The BMI is 29. The patient is in mild respiratory distress and examination shows normal JVP, no lymphadenopathy or normal heart sounds. There's diffuse crackles, head on both lung field, diffuse fine crackles. Leukocytes are elevated. CT scan of the chest shows bilateral micronodular interstitial pattern. Blood cultures are negative. Which of the following is the most likely diagnosis? Okay.
Hypersensitivity pneumonitis.
Why?
Because of the acute nature of the onset of symptoms and the recurrent previous episodes that the patient had.
Nice. What else? What else support it here?
Leukocytosis.
Leukocytosis. So if you look at the presentation, this is looking like asthma, fever, chest tightness, dyspnea, dry cough. You can see that the wheezing is not there. So keep it already. It could be hypersensitivity pneumonitis. We now come down, examination findings. They told us that there's a diffuse crackles. We don't hear crackles in asthma. We hear crackles in people with interstitial lung disease. They can have crackles. So, and now this guy is now having micronodular interstitial pattern again, confirms our diagnosis with leukocytosis. So this guy is definitely having hypersensitivity pneumonitis. It's as simple as that. So, so moving on to the pneumoconiosis. So this refers to exposure to the organic or the non-organic dust. A lot of them, they're occupational lung disease. So people that work in some certain occupations, they are the ones that get exposed to all these things. So the first we have here is asbestosis, and This one is very common in people that work in tile industry, like mechanics, brake lining, mechanics, insulating, company, construction, demolition, and shipbuilding. So it doesn't happen after like 1 or 2 years. So it takes a while. It must have been exposed for like 15 to 20 years. So afterward, they start developing feature of asbestosis. And what is going to be the imaging finding? So don't forget the way they will present is very similar to other interstitial lungs is ILD. The dry cough, the distal exertion, if you listen, we are going to hear the frying crackles, the frying vehicle like crackles in the lungs. Pretty much the same thing. By the time you start doing the imaging, that's when you now start seeing the difference. Now, I remember it by looking at the fact that asbestos should be in the roof, but the pathology is going to be in the base of the lungs. So they're going to be having like linear opacities and interstitial fibrosis at the base of the lungs. That's what the X-ray is going to be showing us, and that's what the question is going to tell us. And to now add to that, they're going to be having calcifications or plaques in the pleura. So if you look at this image here, the pleura is surrounding the lungs. So we are going to be seeing like all this white stuff here. This white stuff here. So that's like, no, that should, is it here? Pleural calcification. It's not very, okay, yeah. No, I'm not sure that's that. Let me check for another image. It's not the pleural calcification. You just see it lining the lungs. Pleural calcification CT. Okay, yeah. So this one is a very good one. So if we see this kind of thing in our exam, we should not overthink it. That is a pleural getting calcified. This is a very good example. Pleural calcification. Just look at the margin of the lungs. That's where we have the pleural. So once you see that, think about asbestosis. Pleural calcification, asbestosis. So yeah. So and if we do like a lavage, we are going to stain for the ferruginous body. So these are just like dumbbell ion containing bodies that are visible using the Prussian blue stain. So let me show us what it looks like in case they show us in our exam. Ferruginous body. Ferruginous body. So it's very classic for asbestosis. Ferruginous bodies. It looks like greenish, golden brown, greenish, blah blah. So this is it. These are the ferruginous bodies. This is what it looks like. So once you see something like this in our exam, of course, it is the only one that will have all these kind of things. So if you are thinking of any pneumoconiosis, and it shows a gram stain, definitely we know it's going to be asbestosis. That's going to be the ferruginous body for asbestosis. So don't forget the fact that there's going to be plaque calcification, and there's going to be linear opacity at the lung base. So it increases the risk of mesothelioma. In fact, it is only asbestosis that can cause mesothelioma. But if it's going to cause cancer, it will rather cause lung cancer rather than mesothelioma. So it commonly causes bronchogenic cancer than mesothelioma, but asbestosis is the only cause of mesothelioma. So we should get the difference. If they list that what's the most likely complication of asbestosis and they put mesothelioma there, don't pick mesothelioma. It's going to be lung cancer first. So we should get the difference. Then the co-worker, so people that work in coal mines, so they are going to have small nodular opacity in the upper lobe, not the lower lobe now. It's going to be in the upper lobe, small nodular opacity. And same with silicosis too. So, but people that can get exposed to silicon are people that play with sand, because the chemical constituent of sand is SiO2, silicon. So people that work in foundries, pottery, that they use clay, glass, because part of what they use to make glass is sand. So quarries, mines, they can get exposed to the silical dust, and they can have the small nodular opacity in the upper lobe too. with surrounding eggshell calcification. So if you see eggshell calcification, just pick silicosis. Let me see chest X-ray. Accessory eggshell calcification for silicosis. So once you see that, have a high index of suspicion for silicosis, and so these are the eggshell calcification. It looks like they are depositing eggs. You can see this, you can see this, you can see that, as big as it is. So eggshell calcification, this guy is most likely having silicosis. So you want to, because they have a very high risk of having TB. So they have to be like annual TB, annually, not monthly, not 2 yearly, but annual TB testing for silicosis. And problem is high up, unlike asbestosis that is down. Then berylliosis occur. They can get it like people that work in alloy, people that work in companies where they use a lot of alloy products, like all this high technology stuff, like building aeroplane, nuclear weapon, electronics, because they use alloy metals to make all these things. So aerospace, nuclear weapon, electronics, ceramics, foundries, dye, they can get exposed to the beryllium, and that one is going to cause like diffuse infiltrate in the lungs with highlight adenopathy. So this one can be treated with steroids. So out of everything, you can treat berylliosis with steroids. You can give steroid to treat berylliosis. So these are the ferruginous body, for asbestosis that we talked about initially. So we should not forget that. So the mainstay is just to avoid the trigger, and you can provide supportive treatment. If you can give steroid, give it. They need oxygen, give them the oxygen. Then the last one I'm going to add is bicyanosis. They can ask us bicyanosis. So bicyanosis is BY BYSINOS. So people that work in textile companies that get exposed to cotton products, if they tell us somebody is having exposed to works in textile and they start coughing, having difficulty breathing with exertion, crackles, you already know that this is bicyanosis, cotton. So don't forget that, cotton, textile, bicyanosis. So what about the eosinophilic pulmonary syndromes? So these are just group of conditions that is associated with high eosinophil blood counts. There's problems with the lung with high eosinophil blood count. So there's a lot of eosinophils infiltrating the lungs and the blood. So this can come from mild, of course, it could be from worms, helminth, it could be from the use of drugs, it could be from this guy, Aspergillus. So one of the commonest cause of the eosinophilic pulmonary syndrome is ABPA, allergic bronchopulmonary aspergillosis. It could also follow Loeffler syndrome. So Loeffler syndrome in people that have ascariasis, and the worm travels to the lungs, and from there, parasites, eosinophils will only follow parasite everywhere they go. And because of the eosinophilic infiltration, they start having the chest pain, the wheezing, the cough, and the likes. And if you do the chest X-ray, you are going to be seeing like opacities, like fleeting opacities because of the worms moving up and down. So eosinophilic granulomatosis with polyangiitis is a very good example, of part of the syndrome. Anybody knows the other name for eosinophilic
Dog stroke.
So how do we identify chest stroke? What are the features you are going to see? Anybody?
Asthma.
Asthma, yes. Asthma. What else?
Yeah.
Asthma is,
They'll
in fact, that's the most provoking symptom that brings them to the hospital. What else?
Eosinophilia.
Okay, eosinophilia is not very specific. Yeah, but it's there. Okay, yes. But what else?
Glomerulonephritis.
Glomerulonephritis, yeah. They can have passive immune glomerulonephritis. Okay.
Positive for Bianca.
Yes.
Yeah,
What else?
sensitivity.
Symptoms. Asthma, yes. What else? Somebody said pulse immune, so that's hematuria. Yes. What else?
P and K positive.
Okay, that's lab.
Hemoptysis. Hemoptysis.
Hemoptysis. Okay, that one is more for good pasture. Good pasture.
Oh,
They usually have nodules. They have subcutaneous nodules. You know, they have like some palpable purpura, and they have neurologic symptoms. Don't forget. So they have like what we call mononeuritis multiplex. So if you see somebody suddenly that's having what's it called? Foot drop. You see somebody having foot drop, and they tell you that the person is having asthma, and they tell us that the person is having some nodules in the skin. Just go and picture. You can see that it doesn't make any sense. You cannot. It looks this. How can you be linking neurologic symptoms with what's it called, with nodules with um asthma? So that is chalk sauce for you. That is chalk sauce. You know, you can see it in any of your former, any of the test form or something. You find it. You know, one of them. I think it's there. So we should pay attention to that. Very, very important. They can be putting all those kind of questions. Just keep it in one of our question, STEM. You know, for people that wants to do well, people that wants to score very high. Once you get those kind of question, because very few people will get it, your mark is just shooting up. So let's pay attention to all those kind of things. So then drug-induced disorder, like people that get exposed to NSAIDs, nitrofurantoin, sulfonamide, they can also have all these things. So how will they present? They have dyspnea, cough, and blood tinged sputum or fever. They can have fever too. So they can have fever, cough, dyspnea, blood tinge. But you can see that this is not actually specific for anything. So you need to go further with the investigation. And just like somebody mentioned, what is common to all of them is the peripheral eosinophilia. And you can say there's peripheral eosinophilia if the eosinophil count is more than 500. Okay, somebody wants to ask a question. Hello? Somebody is raising up their hands. Okay, guys, there's a mistake. So eosinophilia, white blood cell count more than 500 for the eosinophil count, more than 500. If you do chest X-ray, we're going to see the pulmonary infiltrate. So the eosinophils infiltrating the lungs. That's the cause. Then, if we do pulmonary bronchopulmonary lavage, there's going to be elevated eosinophil. They are going to be more than 25%. So, if you can marry all these things together, we'll be able to make diagnosis of eosinophilic pulmonary syndromes. So, if they not tell us that somebody's using drug, sulfonamide, NSAID, nitrofurantoin, we know that that is the cause of all these things. If they tell us that the person is having, we do like precipitin test for aspergillosis, or we test for IgE against aspergillosis, it's positive. We know that okay, this is likely to be ABPA. We do like ovan parasites, and we're identifying the hex of ascariasis. We know that this person is having Loeffler syndrome. Very important stuff. So let's take them one by one. I think the one we have is the Loeffler syndrome, which I explained. So this guy will have cough, they can have chest pain, they can have fleeting migratory pulmonary opacity because the worms are moving. And of course, there's going to be peripheral blood eosinophilia. So they could also be having diarrhea, or it could be intestinal obstruction, because the ascariasis can cause anything. It can cause intestinal obstruction, it can cause diarrhea, malnutrition, but have a high index of suspicion if you are seeing fleeting migratory pulmonary opacity with peripheral blood eosinophilia. Think about Loeffler syndrome. Now, somebody might ask me, when we are talking about COP, we said there's going to be fleeting or migratory pulmonary opacity, but COP is not going to cause peripheral blood eosinophilia. So that's a way to rule out that. So just look for the underlying cause and treat it. If it's a drug, stop it. If it's a worm, give albendazole, and remove the worm. Sometimes you might also need to give them steroid to bring down that high eosinophil count. Don't forget, when we are talking about the stable COPD, and I said people in group E, you might need to add ICS when their eosinophil count is more than what? 300. So don't forget about that. So steroid is very good to bring down the eosinophil level. So moving on to ABPA, allergic bronchopulmonary aspergillosis. So this is hypersensitivity reaction to aspergillus. And one thing I want us to know is that to further consolidate our diagnosis in our mind, always check the question, does this person have history of asthma or cystic fibrosis? Most of the time, one of them is going to be there, because that is what is increasing the hypersensitivity to this aspergillus antigen. So, and when we're talking about bronchiectasis, we said that ABPA is one of the causes, because there's hypersensitivity to aspergillosis, which is recurrent. So there's going to be recurrent inflammation, obstruction because of mucus. There's going to be mucus, which will lead to obstruction. At the end of the day, there's going to be permanent fibrosis, dilatation, of the bronchial airways, leading to bronchiectasis. So one of the common complication of ABPA is what? Bronchiectasis. By the time they start having foul-smelling breath, coughing, purulent, sputum, we already know that they're having bronchiectasis already. So there's always a background of asthma or cystic fibrosis. For ABPA, there's always a background of asthma or cystic fibrosis. So what do you do when we see somebody with asthma or cystic fibrosis having fever with purulent discharge, hemoptysis, and we are thinking, maybe this person had ABPA that is now causing bronchiectasis. So what do we do? Okay, let's go and test for aspergillus. So you do aspergillus specific IgE. You want to see, does this person even have IgE which is specific for aspergillus? Or you try to do a skin prick test. So you inject the person with aspergillus antigen and you check for reaction. So that's going to be a type 4 hypersensitivity test, right? So you check, is there any induration, is there any erythema, is it reacting? If any one of this stuff is positive, then you can answer that, oh, this guy likely has ABPA. But if the person has a negative result, you cannot see IgE specific for aspergillus, you cannot find any positive skin prick test, don't proceed further. But if you find it, you cannot measure the total serum IgE, which you expect it to be more than what? Anybody? More than, okay, no, that's not IgE. You measure IgE and you measure eosinophils, so the value is already there, which you expect it to be more than 500 for eosinophils. And you also do your aspergillus precipitin. So aspergillus precipitin are just IgG against aspergillus, but the most sensitive one is the IgE against aspergillus. Then, just like any other eosinophilic condition, you are going to see the Charcot-Leyden crystals. They are just like pyramidal crystals, which are formed from, the eosinophils. So they look bipyramidal Charcot-Leyden crystals. And if you do a culture of the sputum, you are going to grow aspergillus. So if you do a chest X-ray or CT scan, you are going to be seeing evidence of bronchiectasis. Is normal. So the way the question usually comes, somebody is having asthma, and the person is having maybe fever, chest pain, wheezing, and all those things, and they give the person antibiotics, it's not going down. Think about, allergic bronchopulmonary aspergillosis. It's not going down. It means it's not the bacterial stuff. So you want to think about aspergillus as well. So you have to investigate along that line by checking for the aspergillus specific IgE, skin prick test for it. Then you can measure all these labs we have talked about. So how do we treat? So give steroids, just like we have said initially, and you give the amplified medication, which is what? Itraconazole. If you can't give itraconazole, give voriconazole. So don't forget, anytime you are treating ABPA, just go and give steroids or combine it with the antifungal agent. Very, very important. And you want to optimize the background cause of the problem, which is the cystic fibrosis or the asthma. So for asthma, hard biologic agent, something that can attack the IgE, which is what? Omalizumab for them. For cystic fibrosis too, it said that you can also use the omalizumab. So just try to reduce exposure to aspergillus, maybe from work or exposure in the field or something. Just limit it, aspergillus exposure. Don't be soaking like all these wet clothes. They should not be putting it in the house and be spreading wet clothes that can grow the molds of all this fungi. So what are the complications of ABPA? It could cause acute or chronic invasive pulmonary aspergillosis or aspergilloma. So aspergilloma occurs when somebody that has like a cavitary lesion, maybe the person has a previous history of TB or COPD or something. No, COPD will not cause that. TB or sarcoidosis or anything that can cause cavities in the lungs. Then the person that get exposed to the, aspergillus, organism. The aspergillus organism can form a ball of fungus and sit in that cavity. So we'll notice that the person might be asymptomatic most of the time. It is an incidental finding. Maybe the person is doing chest X-ray for any other test. They'll just see the ball of fungus there. And they'll notice that when they change the position, the ball of fungus will be shifting with movement. That's classic for aspergilloma. So most of that is indolent. They don't have anything, but sometimes this ball of fungus can erode into a nearby vessel and they can have serious hemoptysis, that might be difficult to control. And they can also have chronic invasive pulmonary aspergillosis. So this one is very common in people with background immunosuppression, HIV/AIDS, transplant people on steroids, immunosuppressant, and the like. So they'll be having nodular lesions in the lung, cavitary lesion in the lung, and it will disseminate to other parts. They can go to the brain. They have like meningitis, can go to the liver, go to the bone, So that's chronic invasive pulmonary aspergillosis. So you give the voriconazole here too. Don't forget about that. Give the voriconazole. Yeah. So I think that's that. I think we should stop at this point because if we start going into all these parts, I need her to be well relaxed to be able to take in all those parts. So let's just stop here and see. And let me just attempt that last question with us, and we call it a day. So just take it from that part next time. Okay. So a 62-year-old man comes to the office due to a year of progressive external dyspnea and dry cough. He lives by himself and he has been having difficulty performing daily activities. The patient had a history of GERD and osteoarthritis. He smoked a pack of cigarettes daily for 40 years and drinks alcohol occasionally. The patient works as a carpenter for 20 years, and before that, he repaired Navy ships. He has no pets, no travel history, blood pressure is 140, pulse is 80, BMI is 33, chest X-ray shows pleural calcification, pulmonary function tests are as follows. FEV is decreased, FVC is decreased, the ratio is normal, the diffusion capacity for carbon monoxide is decreased. Which of following is the most common cause of this patient's symptoms?
Occupational exposure.
Occupational exposure. So
Lifestyle.
what's our specific diagnosis?
Asbestosis.
Asbestosis. Okay. Thank you very much, everyone, for your attention. Do you have any question? Any question? How do we
Yes, sir.
find? Okay, I'm with you, sir.
It is not subject related. I just want to confirm if we are meeting tomorrow.
No. We are going to meet on Wednesday, please.
On Wednesday, okay. Thank you.
Do you have any other question? How do we find the respiratory? I know it's very boring. Is it boring?
It's good actually.
It's not boring actually.
It's better than ethics.
It's better than ethics.
Yeah, but the ethics was good as well. It is good.
So I'll just encourage you. Let's just try to master it. We are going to see a lot of recipe in our exam. There's a lot of recipe there. So, but the mistake many people make is that they just like look over it that it's just recipe. Let me just know it. But let me just till the soil. Don't till this. Try to know it. Even if you are going to forget it after the exam, just learn it and painstakingly learn it for the exam because so that I will not be shocked by the amount of stuff we are going to be seeing. So I will be fully prepared. So me too, I didn't like ethics. I didn't like I don't like ethics. I don't like recipe, but I had to like put my head down and just read it because I know that it will be a disaster if I go to the exam and I'm banging, ethics questions. So we are going to be fine. Let's just painstakingly try to learn it, get familiar with all these things we are talking about, because that's the way it's going to come out in our exam. I can assure you. That's once you can just, highlight all these things from the question like that, pick it like that from the question, it's going to be like a walk in the park for us. So there's no problem. So we are going to meet on Wednesday, God's willing. All right. Bye, everyone. Bye.
Thank you.
Bye.
Thank you.
You're welcome.
Thank you.